common type 1. It's so the development of, I'm sorry, the slides aren't matching up. Sorry. Okay. So in type 1 diabetes is an interaction between genetic susceptibility, environmental factors, the immune system. Beta cell destruction occurs from this autoimmune process, and this destruction happens at a variable rate influenced by genes, age, ethnicity, and diabetes autoantibodies. Genetic factors, so the HLA region on chromosome 6 plays the most important or contributes the most to this genetic predisposition, and other non-HLA genes play a role for the development of type 1 diabetes. The overall population risk of type 1 is 0.4%, but in individuals who have a first degree relative with type 1, that risk increases by 15-fold, keeping in mind that 85% of those with a new diagnosis don't have a family history of diabetes. So as we said, there's a genetic predisposition triggered by an environmental factor, whether this is a viral infection, diet, alteration in the gut microbiome. This will lead to beta cell destruction and autoimmunity. And it's important to note that this autoimmunity happens years before the clinical presentation of type 1 diabetes. So this brings us to the stages of type 1. So as you can see, we have a genetic risk followed by some kind of trigger and immune activation. And then we go to stage 1, where you have multiple autoantibodies, but still having normal glycemia and asymptomatic. In stage 2, individuals will have multiple antibodies, dysglycemia, but not necessarily florid symptoms. And in stage 3, this is where clinical symptoms of diabetes are evident. So you'll have polyuria, polydipsia, and clear hyperglycemia. And I'm focusing on this part because of the importance of diabetes-associated antibodies in establishing the diagnosis of type 1 diabetes. So these autoantibodies, most commonly anti-glutamic acid antibody, islet cell antibodies, insulin autoantibodies, and zinc transporter antibodies are important diagnostic tools, and their presence helps confirm the diagnosis of type 1. And they're especially helpful in obese adolescents to confirm that this is type 1 versus type 2. And also just to keep in mind that after a few years, they may become absent. So if a few years after diagnosis, you start to question the accuracy of your diagnosis, they may be negative later on. And also the number of antibodies. So having a single islet cell antibody confers a 15% risk of type 1 within 10 years. But then the more antibodies you have, the more likely you're going to develop type 1 diabetes over the next 5 to 15 years. In terms of type 2 diabetes, it results from an interaction between, again, genetic, environmental, and metabolic causes. And this risk is different between individuals, and among different populations. There's no autoimmunity leading to the deficient insulin secretion. It's mostly insulin resistance from the hepatic or peripheral, resulting from hepatic, peripheral, or adipose tissue insulin resistance, with a relative insulin deficiency due to impairment in beta cell function, defective alpha cell function, and impaired incretin effect. And so you can see here that genetic factors, lifestyle, all contribute to insulin resistance. If beta cell function is still normal, then you'll have compensatory hyperinsulinemia, and the individual is able to maintain glycemia. However, with time, beta cell function starts to become affected, leading to a relative insulin deficiency, hyperglycemia, and symptoms of type 2 diabetes. And so depending on where you are on the spectrum, the symptoms, insulin secretion may be different. The risk factors for type 2 diabetes, as we all know, is obesity, being of a high-risk ethnic group, having a first-degree relative with type 2, and then maternal diabetes during pregnancy, and use of atypical antipsychotics. The signs of insulin resistance to suggest that this individual might have type 2 versus type 1, the presence of acanthosis, the presence of other features of the metabolic syndrome like hypertension, dyslipidemia, non-alcoholic fatty liver disease, PCOS, and being born for small for gestational age are all risk factors for insulin resistance, developing insulin resistance. Just a quick note on type 2 diabetes in pediatrics compared to adults. So in pediatrics, type 2 diabetes is actually an aggressive disease. It progresses more rapidly to needing to insulin dependence, with more rapid loss of beta cell function and loss of glycemic control compared to adults. So it is a bigger problem when you have type 2 diabetes in an adolescent compared to type 2 diabetes in an adult. We're going to move on to so I'm going to move on to monogenic diabetes. It's a result of a defect of a single gene or chromosomal locus. It's inherited either as autosomal dominant, autosomal recessive, or non-Mendelian trait, and it may present either. It may also present spontaneously or de novo. So, in rare cases, there might not be a significant family history. From 1 to up to 6% of autobody negative individuals who are initially classified as type 1 or type 2 diabetes end up having monogenic diabetes. So it's important to always think about once you have any warning signs that I'm going to talk about. It can be categorized into neonatal or early infancy diabetes, MODY, diabetes associated with extra pancreatic features, or monogenic insulin resistance syndromes. So I want to think that maybe my patient doesn't have straightforward type 1 or type 2 diabetes, and maybe this is more of a monogenic form. If diabetes presents in a really young age, so before 6 months or between 6 months and 1 year, and they have no autoantibodies, then you should suspect monogenic diabetes. If you have other features such as other congenital defects or an unusual family history, especially if there is a family history of diabetes in a parent and in other first-degree relatives, and then if there's absence of autoantibodies or prolonged honeymoon period, then you might suspect monogenic diabetes and go for further testing. When initially suspecting type 2 and then the picture doesn't really fit, so if a patient has mild fat, I'm sorry, I think there's a problem with the slides coordination. Okay. So in mild fasting hyperglycemia, especially if a patient is young and non-obese and asymptomatic, this is suggestive of MODY type 2. Lack of consistent severe obesity in other family members who are labeled as type 2 diabetes, or not having very clear signs of insulin resistance in the individual. So no clear acanthosis, no clear other markers of metabolic syndrome like hypertension, dyslipidemia, or having an unusual fat distribution, which might suggest something like a lipodystrophy syndrome. So, diabetes in youth is a heterogeneous disorder, as we said. It has variable clinical presentation, disease progression. However, classifying diabetes and establishing the right type is very important to personalize management and allow the proper management plan to be implemented. But it's important also to know that sometimes classification is not clear at the time of diagnosis, and so we go with what we have, and then with time the picture will become more clear. So I have this table, which is really the, let's say, classical or traditional thinking of type 1 versus type 2 diabetes. I'm going to focus on it and then highlight the exceptions between the different, between maybe what the traditional thinking was and what's actually happening right now. So in terms of onset, type 1 diabetes is usually sudden. Usually there's a history of 2 of polyuria, dyspepsia, the family presents to medical care, the child is diagnosed with type 1 diabetes. However, if the onset is more gradual, so it's been a while since maybe they've had on and off symptoms, maybe they've been told they have diabetes but didn't seek medical care, and there was no progression of their symptoms, and that's suggestive of type 2 diabetes. In regards to age of onset, so classically, the traditional thinking or the traditional paradigm is that type 2 diabetes is a disease of adults, type 1 diabetes is a disease of children. However, that's not true, especially with the increasing rates of obesity, the prevalence of obesity increasing in the pediatric population. We're seeing more and more adolescents who are obese or overweight presenting with type 2 diabetes, and even rarely prepubertal children with severe obesity presenting with significant acanthosis and type 2 diabetes. So age right now is not necessarily a differentiating factor depending on other clinical characteristics. With regard to body habitus, again, classically we think that type 1 diabetes occurs in thin or normal weight individuals, while type 2 is more for the overweight obese category. However, with the increasing prevalence again of obesity in the pediatric population, an obese adolescent presenting with diabetes may or may not be an obese adolescent with type 1. So again, obesity is not necessarily a differentiating factor, and 20 to 25% of adolescents with type 2 diabetes may not be obese at presentation. And the reason for this could be either because in some populations, so this data is from a meta-analysis looking at different populations presenting type 2 diabetes, either these populations have a higher risk, a higher predisposition to insulin resistance, so they don't need to get to that level of severe obesity or obesity to have these manifestations, and that they start to manifest insulin resistance and progressive beta cell dysfunction from even lower weight categories. Or that at presentation, some of these adolescents may have had some metabolic decompensation. They have some weight loss, so their initial Pre-presentation weight was on the higher side, they're probably obese, but by the time they seek medical advice, they've had significant weight loss, so they're maybe now categorized as obese or even high normal. In terms of ketoacidosis, so ketoacidosis is classically common or classically associated with type 1 diabetes, and it's supposed to rarely occur in type 2 diabetes. However, up to 10% of adolescents with type 2 can present with DKA, and this risk is higher in ethnic minorities like African Americans, in males, and in younger patients aged 10 to 14. So having DKA is not necessarily 100% type 1. It's going more towards type 1 than type 2, but doesn't 100% rule out type 2 diabetes. So with regards to autoantibodies, so this factor is probably the most important distinguishing characteristic between both types. So having 2 or more autoantibodies is a near certain predictor of type 1 diabetes. However, there are a minority of patients who present with DKA insulinopenia and have no clear evidence of autoantibodies, especially if they're of African or Asian descent. So there's a small group of patients who might be autoantibody negative but behave like type 1 diabetes and have absolute insulin resistance. On the other hand, there's a subgroup of patients with type 2 diabetes who may present with 1 positive antibody. And this group seem to be more insulin resistant, more defective beta cell function, and have a rapid progression to insulin therapy. So in today's study, a study that was basically focusing on a cohort of adolescents with type 2 diabetes, up to 10% of the participants in this group had pancreatic autoantibodies, and they were less likely to be obese, less likely to have a family history of type 2 diabetes, or belong to a high-risk ethnic group. And so this suggests that maybe there's some degree of interaction with these autoantibodies and the beta cells, accelerating the beta cell defective function and causing them to present in type 2 diabetes. Also, other way around, so obesity and autoantibodies. There is an association between obesity and increased prevalence of pancreatic autoantibodies. And again, these individuals have more insulin resistance and more significant impairment in their glucose metabolism. And also there's some evidence that excess BMI promotes the progression from 1 antibody to multiple positive antibodies and accelerates the progression of type 1 diabetes. So again, autoantibodies are probably very helpful to distinguish between both types, but there are some exceptions to keep in mind when evaluating your patient. Finally, endogenous insulin. So in type 1 diabetes, there's no endogenous insulin, whereas in type 2 diabetes, it could be variable. They could still have normal insulin secretion increased or decreased. And this figure here demonstrates or illustrates the insulin secretion in a number of obese youth. So the top line with the triangle shows you a normal glycemic obese youth who has probably normal or exaggerated insulin secretion in the first phase and the second phase, allowing them to maintain normal glycemia. However, with time, or the second group who have impaired glucose tolerance, start to have defective insulin secretion in the first phase after in an OGT test, but still maintain insulin secretion in the second phase, able to somewhat maintain impaired glucose tolerance, but not going into full type 2 diabetes. And then once individuals progress to type 2 diabetes, you have a clear defective insulin secretion. Or at least it is not, even if it's normal, it's not appropriate to that degree of hyperglycemia. So again, insulin can be low in type 2 diabetes, but it's always low in type 1. With regards to complications between both types, so type 2 diabetes is also more aggressive compared to type 1 when it comes to complications. So adolescents with type 2 diabetes are at high risk of having complications, whether it's nephropathy, neuropathy, retinopathy, or arterial stiffness. And youth with type 2 diabetes are more likely to have a number of comorbidities like hypertension, dyslipidemia, non-alcoholic fatty liver disease. So I'm just going to quickly go over a couple of cases. We have 2 13-year-old boys who present with polyuria, polydipsia, and weight loss. The first one, you get called from the PICU, he has severe DKA. Upon reviewing the chart, you notice that he's obese. So you start thinking, this is most likely type 1, but could this be another type of diabetes? You go in to talk to the family, you notice that the father has vitiligo. So again, leaning more towards type 1 with this autoimmunity in the family. On examination, he has mild acanthosis nigricans. So still, I'm 100% sure this is type 1 or type 2. You decide to order further investigations. His insulin and C-peptide come back very low. And about a month later, in clinic, he has positive anti-GAD antibodies, confirming the diagnosis of type 1 diabetes. On the other hand, the second
3 minutes. Okay, 3 minutes.
On the other hand, the second boy presents with polyuria polydipsia. From the family, you learn from them that he's been told he had diabetes 3 or 4 months ago, but they had some social issues, trouble with eligibility, so didn't present to medical care until now. He's obese and he has acanthosis nigricans on examination. So this is all favoring type 2 diabetes. But when you look through his chart, you notice that he has positive urine ketones. So just in the back of your head, it's most likely type 2, but let me just make sure I'm not missing anything. You send for insulin and C-peptide and they're low normal. So again, probably type 2, can go with type 2, but still not 100% not type 1. Antibodies come back and they're negative for anti-GAD, confirming type 2 diagnosis. Sorry. So why is all this important? As we said, sometimes classification at diagnosis is not that clear. So how does this affect our management? For the most part, most children, if you look at the second and third column, children who present with type 2, if they're in metabolic decompensation, if they have significant hyperglycemia, if they're in DKA, you're going to start subcutaneous insulin, which is the same management you would do for an adolescent who presents with type 1 diabetes. So in all cases, you're going to start subcutaneous insulin, plus or minus metformin, depending on your clinical suspicion and weighing, is this type 1 versus type 2. After that, within the first month, you'll probably get your islet cell autoantibodies. And so if they're negative, this is most likely type 2 diabetes. You're going to continue metformin. You may or may not start to wean subcutaneous insulin and might consider adding another agent. Whereas if the antibodies are negative, if the antibodies are not negative, so if they're positive, then this is most likely type 1 diabetes. And so you're going to continue on insulin therapy. So at the end, you're going to start your insulin, you're going to follow up this patient, try to adjust their blood sugar readings as much as possible, as best possible, and then based on the antibodies, adjust your management depending on which type of diabetes you confirm. So this brings me to the end of my presentation. My take-home messages are that diabetes in youth is a heterogeneous disorder, and it's important to know what type of diabetes you're dealing with so that you can appropriately personalize your therapy. But sometimes it's difficult to establish this diagnosis, this clear type of diabetes at diagnosis. And so therefore you need to use a combination of clinical features, investigations, family history to make your diagnosis. Thank you.
Shukran, Dr. Haifa. Thank you for your nice clear and informative presentation, and thank you for your sticking to the time. And we will allow for 1 or 2 questions from the audience, please, if you have any question or comment for Dr. Haifa. تفضل يا دكتور.
Thank you for your nice presentation. My question is that if the child is not obese and his autoantibodies are negative, usually most of the hospitals, they are doing 2 antibodies. So what is your recommendation for monogenic panel? Should we do other antibodies first or?
So obviously when we talk about autoantibodies, we have at least 3 or 4 that we can measure. Usually, at least where I work, the anti-GAD antibody is the one that's easily available. Some of the other ones are difficult to get. But if suspecting that this is if it's a non-obese individual who's with very classical type 1 diabetes symptoms or diabetes symptoms, very classical type 1, you might not need to do autoantibodies. And I don't think having 1 negative antibody would preclude the diagnosis of type 1 if otherwise everything is fitting, especially since sometimes the extra autoantibodies are not available. Does that make sense? Because you're not suspecting type 2 if it's a thin individual, even if they're an adolescent, if I understood the question correctly. Sorry? Oh, with monogenic, yes, you might consider it. Usually if the child is very young, if they have if they're very young or they have a prolonged honeymoon period or have other features or congenital anomalies, you'll consider monogenic diabetes. But usually in the, let's say, 4 to 5-year-olds to adolescents who are typically type 1, unless they have a suggestive family history, where you might suspect a monogenic type, and or they have a prolonged honeymoon period, you may not need to go further for testing for antibodies, especially since I don't think antibodies are available everywhere.
We will take one more question because of time. تفضل دكتور. واحد فيكم أي واحد. المايك لو سمحت. المايك.
Thank you very much for this very nice and clearly made presentation about a very important topic. In the last 3 decades, we have been through moving from one classification to the other, and probably the last classification we as pediatricians are using is in place for the last maybe 15 years or 20 years. Based on what we heard yesterday from Professor Bayan into that different way of classifying diabetes into clusters, cluster 1 and 2 are applicable to the pediatric population. Where are we at, and how long will it take us as pediatric endocrinologists to start changing our language in describing diabetic children?
I'm sorry, I didn't attend the presentation yesterday with Prof. Bayan about the cluster diagnosis or that kind of that terminology, so I'm not very familiar with it.
Okay, please. Last question.
Thank you very much, Haifa. Very elegant talk. Frequently, we see now type 1.5. What's your comments about that? Because we see type 1 who are negative in antibodies, and eventually they become positive.
So I think type 1.5 are that category who are either, if you remember my slide, either they're obese and they have evidence of autoantibodies, or they're type 2, they have type 2 diabetes, but they're that subset who has one positive antibody. So I think there's overlapping and maybe a lot of gray area, which highlights the fact that at the end of the day, I'm going to treat with insulin, plus or minus some of the type 2 diabetes medications, depending on the clinical presentation, the investigations, and the further progression of the course of the disease itself. So I think type 1.5 could either be an obese type 1 who has insulin resistance, so needs more doses of insulin compared to a thin or lean type patient with type 1 diabetes, or it might be the subcategory of type 2 diabetes who has one positive antibody who rapidly progresses to insulin dependence.
شكرا دكتور هيفاء, الله يعطيك العافية, and I will give the mic for Amit to present the second speaker.
Thank you. The second will be Dr. Najia Atiya. She is a consultant pediatrician and pediatric endocrinologist, King Abdulaziz Medical City, National Guard, assistant professor, Department of Pediatric and College of Medicine in King Abdulaziz University for Health Science, Jeddah. Dr. Najia will talk about disorder for sex development.
السلام عليكم ورحمة الله وبركاته. جمعة مباركة. I am really happy to be with you today, and I would like to thank the organizing committee for choosing the subject and inviting me to this symposium. I will start actually with this is around the world. This is a pronouncement is heard every second. It is a boy, it is a girl. But you can imagine how distressing when the birth attendants unable to make such pronouncements. What's happening? It is ambiguous genitalia. The genital appearance does not permit the gender declaration. And actually, this is not uncommon. It happens like one every 2,000. It is not moving, yeah. 2,500, and unfortunately, most of the time, unanticipated. This ambiguous genitalia. It's not working very well today. Maybe out of battery or what? Okay, well, so if we ask why this ambiguous genitalia happens, it is due to the DST. It's not working. Can you change it or anything? Yeah, so if we ask all ambiguous genitalia are DSD, but not the opposite. So what is causing disorders of sex differentiation? So if we We have to answer this, we have to go to the normal steps of normal sex differentiation. Again, it is not moving. Yeah, so this is the steps of normal sex differentiation, and it is 5 steps. I have to be near to here. I have to be, because it is not, okay. The first step, it is genetic sex, and at the moment of conception, the embryo either female XX or male XY. The second step, it is the formation of undifferentiated structure usually occurs at about 4 to 5 weeks gestational age, and it consists of 2 sets of internal sex ducts, like Wolfen ducts, male Wolfen ducts, and the female Mullerian ducts, gonadal ridge and germ cell, and neutral external genitalia. In the step number 3, gonadal sex at around 6 weeks of gestational age, this gonadal ridge with the presence of Y chromosome and SRY gene, it will be differentiated into testes. But in absence of Y chromosome and SRY gene, it will differentiate in XX2 ovaries. And the step number 4, gonadal hormone in presence of testes, from Sertoli cells, it will secrete anti-Mullerian hormone, which lead to regression of Mullerian ducts, and the testosterone will lead to masculinization of Wolfen ducts into epididymis, vas deferens, and seminal vesicles. In case of female, because there is no testosterone, no anti-Mullerian hormone, so the Wolfen ducts, the male Wolfen ducts will be degenerated, and the Mullerian ducts, female, will differentiate it into fallopian tubes, uterus, and vagina. And the last steps, which it is the most important one, which it is the phenotypic sex. It is usually start at 9 weeks of gestation and end at 12 weeks of gestation. And in this step, in undifferentiated or neutral external genitalia in presence of testosterone that converted to dihydrotestosterone by 5-alpha reductase, it will be differentiated into male external genitalia. And in absence of testosterone, will differentiate into female external genitalia. So the DSD will happen if there is any disorder disrupt any normal step of normal sex differentiation. And actually it is not uncommon. It happens like 1 in 1,000 to 4,500. And this is actually the last classification of DSD. It is the updating of Chicago consensus for the DSD. And it is divided into the first category, 6 chromosome DSD. And this category, it includes abnormality of number of chromosomes, mainly like Klinefelter syndrome, Turner syndrome, or mosaic. And the second category, 46 XY DSD, and this is, it includes any disorders in testicular development or any disorders in androgen production or action. For 46 XX DSD, it includes also disorders of ovaries or excessive androgen production from the mother during pregnancy or from placenta or fetus. And they, including other, it means that congenital anomalies or other rare syndrome. And I will discuss with you some of our cases. This baby referred for us for re-evaluation. 2 months old baby raised as a female or as a girl, born to consanguineous Saudi parents, and diagnosed congenital adrenal hyperplasia, 21 hydroxylase deficiency, based on equivocal adrenal profile. When we received the baby was already on hydrocortisone and on fludrocortisone, but there was no history of any adrenal crisis. The mom gave us a history that of cystic acne, hirsutism, deepening of voice during pregnancy, and all of these virilizing symptoms disappear after delivery. And mama also denies taking any androgen during pregnancy. And this is the examination no palpable gonad, and there is labiosclerotal fusion, single perineal opening, and the phalanx length was 12 millimeter. So the chromosomes came 46XX and the electrolyte 17-hydroxyprogesterone, dehydroandrostenedione, all were normal, but the patient was on treatment. And ultrasound able to visualize the uterus and ovaries. So actually we think, and we put our provisional diagnosis, aromatase deficiency, and the clues here that there is virilization of maternal virilization during pregnancy and disappear or all of these symptoms after delivery, and there was no lack of any evidence of CH. But actually, because the aromatase deficiency is very rare, so I was not that strong to stop the medication, and I prefer to wait for WIS, which it comes and actually confirm the diagnosis aromatase deficiency. Aromatase deficiency, it is very rare disease with a prevalence less than 1 per a million, and it is usually inherited at autosomal recessive due to the mutation of CYP19A1 gene, which is located on the long arm of chromosome 15. Normally, usually during pregnancy, the androgen from the liver and from the fetus liver and adrenal move to placenta and to metabolize to more active form of androgen. And normally this androgen should be converted to estrogen. But in case of aromatase deficiency, this will not happen, and the excess of androgen moves to mom to cause transient virilization, and to the fetus leads to ambiguous genitalia or virilization of the female XX-DSD. So the treatment, actually, we are discuss it as multidisciplinary team with the mom, and we agreed to stop the medication and to continue female sex assignment and for surgical correction. And well, upon puberty, we have to start a lifelong hormonal replacement therapy. This is to initiate the secondary sexual characteristic and also for the growth and for the bone mineral, and to stop LH and FSH increasing and suppress, and also to avoid ovarian cyst. And we learn from this case that not every ambiguous genitalia is CH. This is the second case, also a 1-month-old girl admitted to BICU due to hyperkalemia, lethargy, and vomiting. First child of Saudi, consanguineous parent, no family history of ambiguous genitalia, CH, or sudden death, and the newborn screening for CH not done. Examination, as you can see, normal female external genitalia, no palpable gonads. Slides not appear. Slides? Yeah. Slides, the first, you didn't see the second case, so we need to see the second case. Second case, please. Yes. The picture of the second case. Sorry, I didn't notice here. Just return back.
معلش يعني على بال ما يتصلح الخلل الفني. جمعتكم مباركة مرة ثانية، وإن شاء الله بإذن الله حيكون الباص جاهز الساعة 11 أو بعد ما ننتهي من آخر محاضرة في السيشن التالي. الباص جاهز هنا جنبنا، من هذه البوابة نخرج على اليمين، حنروح المسجد نؤدي الفريضة بإذن الله، ونوصل تاني إلى الفندق لتناول طعام الغداء، ونكون هنا عندنا الساعة 1:15 حتبدأ الجلسة الظهرية إلى بعد الظهر بإذن الله تعالى.
I don't know what happened. Not for you. Not okay. But can you move this? Yeah, move it more. يعني not this slide. How to? How it? طيب how to? It is not working. لا كيف تقلبها يعني it will be. لا not with me. But this is not working. طيب okay. I don't know, maybe this is the first case. The steroids hormone. Actually, it is also a very rare disorder, and the incidence 1 in 300 births, and it is inherited as autosomal recessive with abnormality in the genes, star genes. This is a star mutation in steroidogenic acute regulatory protein, and it is located in the long arm of the chromosome 8. Okay, then here we need actually the star. We need the star for the cholesterol to enter to mitochondria for metabolism or synthesis of the steroid. And in this figure, I will show you figure more clear. Can you move it? Okay, this is here, if we can see the star here near the mitochondrial. We need the star, we need this protein for cholesterol to come from the lipid droplet to enter for metabolism, for synthesis of steroid. But in case of deficiency or mutation of the star, the lipid started to be accumulated inside the cells. And in the last here picture, you will find here the lipid droplet accumulated inside the cells and destroying the cells physically and chemically, because the cholesterol will oxidize. And in addition to that, there will be no synthesis of the steroid at all from adrenal or gonads. And the end result, can you move it? It will be a decrease in steroidogenesis in adrenal and gonads, increase the ACTH, and adrenal hyperplasia and sex reversal in boy. So the treatment here, we have to use replacement therapy, glucocorticoid, and mineralocorticosteroid. And we have to replace again at the time of puberty with hormonal therapy. So the key message from this case, not all adrenal crises are 21-hydroxylase deficiency, and not all is DSD having ambiguous genitalia. This is the case also, this beautiful girl referred to us from Taif. She is 10 years old, and mama noticed that there is genital swelling or labial swelling while the patient in a squat position. So this is not her picture, but it is more or less similar to it, and even milder than this, because there was very, very minimum posterior fusion, and we didn't feel actually gonads, but we feel like a small mass. Can you please move it? Yes, small mass here, no, before. Small mass located in the labia. Next one, because it's not working. Okay. The karyotyping came 46XY. And the abdominal ultrasound not able to visualize gonads, and we did MRI, and it showed that there is bilateral inguinal testis and no internal female structure. So this patient actually located under this category, 46XY DSD. The patient has normal chromosomes, male chromosomes, normal testis, and there is no Mullerian structures, and the abnormality in ambiguous genitalia in the last steps of the sex differentiation. So the causes here will be partial androgen insensitivity in 80% of cases, or inadequate androgen synthesis in 18%, or 5-alpha reductase. So we did a HCG test, stimulation test. This is the test which I like it actually, it is very useful. And we found that testosterone to dihydrotestosterone is high. So we diagnosed the case as 5-alpha reductase deficiency, and also genetic test came and confirmed the diagnosis. So here we'll find 5-alpha reductase. It is a very rare disorder. There is no prevalence or even incidence rate, and the testosterone needs the 5-alpha to be converted to dihydrotestosterone. And in those patients, usually they have normal, this is due to undervirilization of male external genitalia and normal estrogen and it is very difficult to be like
2 minutes, Doctor.
But we cannot, because we missed a few minutes while we are correcting the. So what about this 5-alpha reductase in this patient? The sixth assignment. Sixth assignment here is very complex, but we have some evidence. The evidence that most of those patients, they have predominant female genitalia at birth. But the gender role and behavior changed to male at the time of puberty in more than 50% of cases. Also, more than 50% of patients, they identify themselves as a man at the time of the adulthood. And we published paper with Prof. Ali Zahrani from King Faisal in Riyadh, Research Center in Riyadh. And it was actually the largest and the first study collecting 24 subjects of 5-alpha reductase. 54% of them raised as a female at birth. And they found that 61% of them converted to male at the time of puberty. And 5 subjects, 38%, continue as a female. None of the male assignment at birth changed to female. Next, please. So what is the recommendation? The recommendation, if we're able to diagnose 5-alpha reductase at a newborn or infantile period, to raise the patient as a male because of the virilization at the time of puberty. But in our case, if we diagnose the patient late at childhood or adolescent, better not to do any surgical or hormonal intervention before psychological assessment of the patient and consulting the family. And this is what we did. And with time, the patient raised, the family raised some issue. Next, please. That we have to, before. And that is a daughter, they noticed that their daughter behavior changed to a male side. So in the multidisciplinary team, we discussed with the family, and they agreed for psychological assessment for their daughter, and which we did it actually over several sessions. And the psychologist came with the end result that the gender identity and role of patient go with the male assignment, and the patient is ready to be converted. And this is after conversion and seem to be happy. Okay, next slide. So how to approach to patient with the DSD? The best approach actually to consider any DSD patient as an emergency condition, because the patient can lose life if we missed a case. Next, please. And those patients, usually the gender assignment must be delayed until evaluation by expert, and should be also managed on expert center. All individuals should receive a gender assignment, males or females. We don't have in between. Okay, the next, please. So this is a multidisciplinary team, and as you know, including members of. Okay, next, please. And we can, this is the team leader. Okay, the next, please. We have to give time. This is the next, please. This is my approach, and of course, not the best approach. So this is, we depend on the gonads. If the gonad palpable, we need to do karyotyping, ultrasound, HCG. If not palpable, karyotyping, ultrasound, 17-hydroxy, and electrolytes. I'm trying to do the minimum investigation because a lot of investigation confusing me. Next, please. So just try to interpret it. If the XX and the ultrasound showed the ovaries, showed the uterus, and there is an increase in 17-hydroxyprogesterone. So this is a case of CH and under the category of 46XX DSD. If the 17 normal, still we have to look for other causes of increasing androgen, so other type of CH, or from the mother or placenta. If it is XY and the absent uterus, so this is 46XY. If mosaic and the uterus absent or uncertain, we need to think of XX testicular, ovotesticular, or mixed gonadal dysgenesis. Next, please. This is XY category, okay, XY chromosomes, and there is absent Mullerian instruction, so 46XY DSD, and please do HCG test and how we can interpret it. If it is normal testosterone to dihydro, this is partial androgen insensitivity in ambiguous genitalia, or complete if normal female genitalia. High testosterone to di, like our patient, this is 5-alpha reductase deficiency. If there is low, so the production of androgen is low, so we have to do synactin test. It helps to know the enzyme deficiency, or we can do the genetic test. It will be much better. If XY absent, XX and absent of uterus and the palpable gonad, think of XX testicular and look for SRY gene. So if it is mosaic or there is a
دكتورة عطية.
okay.
خلاص.
Okay, so
دكتورة
this is,
نجية.
okay.
Huh?
This is the last point, that
Yes.
every DSD patient is unique and should be treated with individualized care, preferable with multidisciplinary team. And actually we did a review published about DSD, maybe of benefit. Thank you.
Thank you. Thank you, Dr. Najia, for this excellent and informative lecture. We have 2 questions. No question? Okay, if there is no question, we will end this lecture and we will start the other session.
طيب شكرا دكتورة. Our next topic is approach for a child with a multiple fracture. Will be given by Professor Adnan Al-Sheikh. He's a professor and consultant pediatric endocrinologist and head of pediatric endocrinology, King Abdulaziz Medical City at National Guard, Jeddah. Dr. Adnan, the mic is you.
Assalamu alaikum wa rahmatullah. Good morning, and mashallah, very good attendance and Friday morning. It must be an interesting session, and I promise, inshallah, this lecture will be also interesting. I would like to thank the organizing committee for arranging this conference and for the invitation and for choosing this important topic, which not uncommon we see in the pediatric practice. Can we start? Can I have the point? Back? Yeah, right. Shukran. Okay, so this is the outline of my talk. Not sure if they can open the screen or... It's okay. It's okay. So maybe I can just come here, but then I need the mic. So these are the outline of what I'm going to cover. I will be fast. So just I'll take you through this journey. So let's start with the basic information. So as you know, bones have 2 types of bones: spongy bones and compact bones. Spongy bones are they call it trabecular, and from the name it's the weak bones. It's not the strong bones. It constitutes about 20% of the adult bones, and it is found at the end of long bones and also in the vertebra and pelvis. Compact bone is the strong bones, and it constitutes about 80% of the bones, and it's found in the shaft of long bones and the outer surface of almost all bones. So bones are kept in a balance between bone formation and bone resorption. The main cells for bone formations are osteoblast, and the main cells for bone resorptions are osteoclast. So there is a balance in between them. If this balance is disturbed, then we get osteoporosis or fractures. Back, I'll go to also other principles. Thank you for opening the screen. Peak bone mass, from studies, it starts around 24 to 30 years. And it's higher in males than in females. And in females, there will it will start to drop suddenly with the menopause, and then both males and females will get decreased bone density. So this is where our bones are more stronger, around the age of 25, 24 to 25 to 30 years. And then there is another concept called bone mineral content. So what is the peak of bone mineral content? In studies it showed in males, it's around the age of 14 and a half, about 2 years after our peak height velocity. And in girls, it's about 12 and a half years. Again, about 1.5 years to 2 years after the peak height velocity. So peak bone mass is really affected by many factors. The main one is genetic factors. Very interesting. I found in the literature that Caucasians has more risk of fractures, where African has less risk of fracture. I think we are in between, but very interesting information. And the other factors which affected the nutritional, like vitamin D, calcium intake, and also protein. So those who are protein malnourished, they have more risk of fractures. And then hormonal factors, mainly 6 hormones, and obviously with the peak of our puberty, with the secretion of 6 steroids, then we get really peak bone mass, and also growth hormone and IGF-1 are very important factors. And then mechanical factors. Exercise and muscle strength has very important effect on the bone strength and peak bone mass, and also body weight and adipocyte hormone. So it's a balance kept between them. If this screen causing a problem, you can switch it off. Yes. Okay, so I will present a very good study done, a huge study done in the UK, and it's involved 7 million population. And the pediatric population were around maybe 1/4 of that. And the rate of fractures was 30% in boys and girls. And in boys, it was more. In girls, I will just show the peak or the graph when they start the screen. And in boys, the peak fracture is about 14 years of age, 13 to 14 years of age. And in girls, around 11 to 12. And the peak in boys is more. And most of the fractures reported were related to trauma, either while playing or doing contact sport. But this is very, very interesting study. It's more common than adults. So fractures in pediatric population are more common than adults. Can we move? And from that study also, it showed that most of the fractures occur at the distal part of the hands or arms, and infants are more with the fractures in the shaft, in the diaphysis, while pediatric children, the fractures more in the epiphysis, in the metaphysis. Adults or adolescents, the fracture more in the epiphysis. And from that study also, they looked, is there is any management protocols or guidelines in the world? And their conclusion that there is really no standard management guidelines for the pediatric fractures. That study was published in 2004. So this is about 20 years. Based on that study, I think a lot of studies looking at the guidelines and putting guidelines, their conclusion, I think it's working now. Their conclusion that they should encourage children to do weight-bearing activities or exercise. They should take really adequate calcium and vitamin D. And from that study also, they mentioned that vitamin D deficiency has to be really treated well. And to keep vitamin D level, initially they put more than 75 nanomole. And the recent recommendation, they put 50 nanomole. Okay. I think they are facing a technical problem. Okay. Next, كمان شوي. Next. So Mr. Chairman will account for this technical difficulty. Okay, so very interesting. So in that study, they found that most of infant fractures were in the shaft. Supposed to be the more strong bones, but it's actually still weak in those infants. In children, it is mainly metaphyseal, and adolescents actually in the epiphysis. And this is the big bone fractures happened. So to diagnose osteoporosis is very easy in adults. They just do the bone densimetry and they follow the T-score. If it is less than minus 2.5, then this is diagnostic for osteoporosis, and osteopenia -1 to -2.5. But in the pediatric population, it can't be the only criteria. There should be more than that. So according to the International Society for Clinical Densimetry, there should be two criteria: low bone mineral density based on the Z-score and the presence of clinically significant fractures, which is either two long bone fractures before the age of 10, or 3 long fractures before the age of 19, and 1 vertebral fracture. Now there is a problem with this definition, because if you face 1 fracture and you said, okay, I will not treat until I see another long fracture, so this is really a defect in this fracture. But if you see 1 vertebral fracture, then you have to go ahead and do the bone mineral density. So these are the two strong criteria: low bone mineral density and significant fracture history or presence. Now, let me move to the main causes of osteoporosis or fractures in children. So we divide them into primary bone disorder or secondary bone disorder. Primary bone disorders are mainly connective tissue disorder of the bones, osteogenesis imperfecta, Ehlers-Danlos, and what we call idiopathic juvenile osteoporosis. Secondary, which is actually more common, we see, especially if you have a tertiary care where there's an oncology center or there is a lot of use of steroids. So prolonged use of steroid, in my practice, it is the commonest cause of secondary osteoporosis in the pediatric population. Then chronic inflammatory disorder like GIA, or we call it in the past GRA, and inflammatory bowel disease. I got good number of our patients with Crohn's disease. Almost most of them, they developed osteoporosis and vertebral fractures because they needed to use a lot of steroids. And other chronic disorder like cystic fibrosis will affect malabsorption or cause malabsorption, chronic liver disease, and then childhood cancer. They will be they will have osteoporosis and more risk of fracture for 2 reasons. First, steroids, and they give mega dose of steroid. You can see they really start a huge doses of dexamethasone for many weeks, and also bone metastasis or bone involvement and a significant time of immobilization. So there is 3 factors on those patients. Neuromuscular disorder like causing immobilization, cerebral palsy, Duchenne muscular dystrophy, and hypogonadism with the primary or secondary hypogonadism, and also other disorder. Now, it's mentioned in the literature, but we don't see, I didn't see as any case of decreased bone density or fracture in type 1 diabetes alone without other risk factors. But thyrotoxicosis, yes, there is cases with. So I'll just go quickly through the primary disorder. The main one we see is the osteogenesis imperfecta. We have a family with Ehlers-Danlos, so they have, and we have a case with homocystinuria, but very interesting. She got not a fracture, she got severe dental abscesses protruding to the jaw bones and needed many surgeries. So they are more prone to that. Pycnodysostoses, we have one case, but very interesting. We have one case. Polycystic fibrous dysplasia, to me, I think it's the second cause in our population because we see a lot of fibrous dysplasia, either isolated or part of McCone-Albright syndrome, and genetic rickets also, and idiopathic juvenile osteoporosis where they excluded other causes. Now, just a few slides about osteogenesis imperfecta, very characteristic. They have a blue sclera. And 85%, the main problem is a mutation in the COLA-A1 and COLA-A2 gene mutation causing defect in type 1 collagen. And I was looking at where they reach. In the past, we are saying 10 types of osteogenesis, and then 14. The last statistics I found is more than 24, actually 25 types of confirmed genetically osteogenesis imperfecta. The commonest is the autosomal dominant. The rare is autosomal recessive, but it is more severe, and usually they have intrauterine fractures or fractures with at birth. So this is the blue sclera, you can see that, and then they got the very characteristic dentagenesis imperfecta, they call in the teeth. And you will not miss that if you see a patient with fractures, with deformities. This is most likely primary bone disorder, mainly osteogenesis. And this is also one of our patients with ribs fractures. You can see that they got significant osteopenia from the x-rays with many osteotomies needed. Can you move the slide? It's not moving. Okay, so secondary osteoporosis. I will go through some of them. So any condition which affect the muscle bulk and causing muscle wasting or muscle weakness or immobilization will cause fractures, chronic inflammation, chronic inflammatory conditions, steroids, hypogonadism. So from this table, you can see that SLE and GRA is the commonest chronic inflammatory condition, and then followed by inflammatory bowel disease like Crohn's. We see that they got a good number, our GI team, they have a good number of Crohn's and ulcerative colitis, so they go into fractures, or at least they will have significant osteoporosis needed treatment. And then cerebral palsy patients, especially if they are immobilized, Duchenne muscular dystrophy, and post-trauma child who has a trauma and he's immobilized for some time. Leukemia, we talked about it, and then hypogonadism and hyperthyroidism, and vitamin D deficiency or genetic causes of vitamin disorder, and chronic kidney condition and steroids. So these are the secondary. Steroids will cause osteoporosis through many mechanisms, but it has a strong effect on bones and a negative effect. So it interferes with the vitamin D metabolism and calcium absorption, also the increased calcium losses. It affects also decrease bone formation, increased bone resorption, and also it affects sex hormones. So these are just some slides. So this is a healthy bone with the fractures after trauma. You can see that there is no osteopenia. But if you look at the Duchenne muscular dystrophy patient, there is significant osteopenia with the fracture, spiral fractures in the cerebral palsy patient, and a patient with GRA with the compression fracture. Child abuse, we don't see a lot of cases with that, but I'm sure maybe because we are a tertiary hospital, but I'm sure you see it in maybe secondary hospital. You can see that with bruises and spiral fractures of the shaft, subdural hematoma, rib fracture, and retinal hemorrhages. And very characteristic also, you find that what they call high specificity fracture. So if they found that, then this go more with that. The only explanation will be in a child with this fracture, if there is no primary disease, this should be a child abuse. Because he doesn't have any osteopenia, you can see that, and he got multiple fractures in the shaft and maybe bruises. So there is a red flags to indicate that. So a high specificity fractures, you have to suspect child abuse. If there is specific skin injuries like cigarette marks or immersion or bench marks, so that go with We in our center we saw few cases. We saw child abuse from the in the family itself. So there was really cases, but it is infrequent. It occurs really in those who cannot express in infants. So how to approach a patient with a fracture? Always in medicine start with history, and history will give us the clue in most of the conditions. So detailed history, how the fracture happened. What is it really trauma? They divide that, if it is low trauma fracture, and there is a definition, but the time is not enough. If it is a fall from less than 0.5 meter, this is low trauma fracture, like he's just getting up from the bed, or he just minimal trauma, then this is significant that this is maybe a fragility fracture. Any previous fractures, back pain, prolonged immobilization or disability, any chronic condition, even if it resolved, it will have an impact on those children. And then estimation from the history of how much you drink milk, are you exposed to the sun, how much vitamin D. So this is vitamin D intake. So these are by history. And then by examination, musculoskeletal examination, they call it PGAL. So it stands for pediatric gait, arms, legs, and spine, and look for any chronic condition. And this is usually obvious by history. And you can exclude also child abuse by thorough examination, assess the weight and height, and then also assess puberty stage. And then we move to the last part, which is investigation. So you have to assess the bone profile, including calcium intake and calcium level and phosphate, alkaline phosphatase and BTH and vitamin D level. And then measure bone densimetry by DEXA, spine radiograph, and genetic testing if you suspect a primary bone disease. So I will just go quickly through 5 minutes. Okay, so maybe I should pass this slide. So the radiological testing or diagnostic technique to assess bone health, 3 things, either the DEXA or the quantitative CT or bone X-rays or radiology. So DEXA is actually the most commonly used tool, and I think it's available in most of the hospital, and it is precise. It will give you really if there is a defect or not, and the preferred site is lumbar spine or total body less head scanning, but it is affected by movement and or scoliosis. And very interesting, they give you color coding report. So either normal, the green one, osteopenia is the yellow one, and osteoporosis is the red one. Now, adult, they use the T-score, which is the adult matched. But for pediatric, we should use the Z-score, which is age matched. So you are matching your patient who is, let's say, 10 years, you are matching him to the bone densimetry of a normal 10 years old. So it has to be a Z-score. So never rely on the T-score because they report both the T-score and the Z-score. So this is how it is reported. So this is a normal patient, and you can see that the spot there in the green. So this is also a normal bone densimetry. This is a femoral scan. You can see that it is -3. So I'm not sure if we can move this, but it is in the osteopenia range. The Z-score, you can see the T-score is -3, but the Z-score is -1.8. So it's in the osteopenia range, okay? And so the benefits is it's a precise, easy to do, not expensive, I would say, and it has really very low level of radiation, and it is considered to be the gold standard. Now, for adults, for the problem that children who are less than 7 or less than 5, there is no reference in the country for Saudi Arabia. I tried with our radiologist, nuclear radiologist, reported, but they say we don't have a reference. So I tried to persuade them to use the Turkish reference, Egypt reference, India reference, but they said no, we cannot report a bone density less than 5 years. One of them, they said less than 7 years. So this is a problem, and I think it's a very good project for us in Saudi Arabia to do the normal, as Prof. Al-Hirbish did the normal growth charts. We can see do the normal chart for the bone density. Now, don't miss to do the vertebral or spine X-rays, especially if you are suspecting fractures or if your patient has a difficulty to do the bone density or he has a scoliosis. And the radiologists use something called Ginant's semi-quantitative method. So I'll not go in details, but they look at the volume and the morphology of the spine X-ray, and then they report the degree of the crush fractures of fracture. CT is a lot of radiation, and I don't think I never requested for a patient, and it has really, but it is indicated if there is a difficulty in a child with severe scoliosis and cannot go in the DEXA machine.
2 minutes,
so this
please.
is okay. I'm finishing. So in management, you have to treat the underlying cause. You have to give adequate calcium, vitamin D, and protein, and look for vitamin D deficiency, and you have to treat. Remember that in our population, the rate of vitamin D or prevalence of vitamin D deficiency is very high, up to 70 to 80% in the pediatric population. And encourage regular weight-bearing activities, so children really has to do activities and sports. If there is a risk of fracture, then avoid contact sport like football. Okay, and specific treatment. The specific treatment is biphosphonate, or sometimes they call it bisphosphonate. And the medication we used to use pamidronate. But the problem with the pamidronate, you have to admit the patient for 3 days. So we never used it for the last maybe 10 years. So we are using zilidronate. It's like 1 hour infusion, and then you observe for 1 hour, and the patient will go home. And you give it initially every 3 months, and then every 6 months. The guidelines underestimate the dose, so be careful. I have patients who are on zilidronate, and they started to have more fracture because they used, our resident or fellows use the Manchester guidelines, which give low dose of zilidronate. If you give low dose, then you have to bring the patient every 3 months. If you give really a slightly higher dose, then you can bring the patient every 6 months. But you can't give the low dose as Manchester guidelines and you bring the patient every 6 months. They will relapse, they will go into fracture. Acute phase reactant is really minimal, but hypocalcemia is significant. I saw patients who presented with tetany or carbopedal spasm just after discharge. If they were not receiving adequate vitamin D, renal impairment, secondary osteonecrosis of the jaw. This is an adult. Okay, I will just go through this case quickly, 1 minute. Okay, so this is a child, Omar, he is 13 and a half years, who presented with needed prolonged steroid courses, prednisone, but he got generalized bone pain and also back pain. Back pain is really very significant complaint. Clinically, the only observation he found that he's underweight and under height, and he did not start puberty yet. And biochemically, he was normal. Vitamin D was in the normal range. But when we did the scan, his bone density is -3 and -4, and you can see that it's hidden here. You know this, but he is in the osteoporosis, in the severe osteoporosis actually. So what next you will do? X-rays. So we did an X-rays, and it showed vertebral compression fractures. That was also assessed by our radiologist. So the suggested treatment, you have to treat the reason or the cause. Steroids. If you will ask your colleague, the rheumatologist, to spare steroid if you can use steroid sparing agents, and of course IV bisphosphonate, and optimize the dietary intake and improve vitamin D status, and if he had delayed puberty, then With that, I would like to thank you for your attention.
شكرا دكتور بروفيسور عدنان. جزاك الله خير for clear and nice presentation, and we'll allow for one or two questions or comments, please. Microphone, mic هناك. صراحة المحاضرات جدا جميلة، معلومات مرة كويسة، لكن نحن we have to stick to time. تفضل.
Assalamu alaikum. Thank you, Dr. Adnan, for the very informative presentation. My question, maybe you have touched on it on your presentation, the use of bisphosphonate and fractures. So we know that bisphosphonates could actually increase the risk of fractures, especially what's called atypical femoral fractures, which has certain features, minor and major features and so on. And sometimes delaying your bisphosphonate may also lead to more fractures. So what is your approach in your center? What do you deal with? How do you deal with fractures on kids with bisphosphonates? Do you take it case by case? Do you just ignore the fractures, deal with atypical femoral fractures and so on?
Thank you, Dr. Hussam. Very good and practical question. The specific treatment for pediatric population is bisphosphonate, mainly zolidronate. There is some good trials on denosumab. It's an adult medication, very good medication, by the way, very safe and less side effect, but it has been approved for adults for many, many years. In pediatric, I just saw one case, I'm not sure, one study, but I'm not sure if it is approved. Maybe one of the colleagues have mentioned. But we never used it for the pediatric population. Back to your question, I did not have time to elaborate on the problems or side effect of zolidronate. So if there is a fracture for any reason, then your treatment is bisphosphonate, and you have really to start it. The sooner, the better. Especially if it is vertebral fracture, because you want to prevent further fracture. Now, the orthopedic colleague will not allow you to start zolidronate immediately. They would like to have 2 month to 3 month gap until healing will occur of the bones. So let's say if your patient is osteogenesis imperfecta and on zolidronate and he got a fracture while he's on treatment, then you have to wait for 2 to 3 month gap before you give the next dose. This is one point. The second point, atypical fracture, it is well-known side effect of zolidronate, but to me, I think the main reason for fracture while the patient is zolidronate is actually inadequate treatment. Inadequate treatment. For reason or another, the protocols are very conservative. Our clinical pharmacists, maybe our fellows will remember, they prevent us to start the high dose. They said we don't have an evidence, and we have to search many evidence, and we found the Australian studies very good. If you look at the references in the Australian guidelines, they use very good dose. They use 0.1 milligram per kg. If you look to other studies, they give small dose, 0.025 milligram per kg. So the main reason, Hussam, and colleagues, for this really fractures while on zolidronate is inadequate treatment.
We'll have one more question, please.
Thank you, Prof. Adnan. Just my question is regarding the chronic diseases, like we see cystic fibrosis patients and we are screening them for bone densitometry. Sometimes they don't have fracture, and even they don't have, we do the x-ray, then there is no vertebral fracture, compression fractures. At times they are a bit short, and their bone densitometry is more than -3 even or -3.5. So what should be, and they are having ongoing risk factors. So what will be your approach or recommendation?
Okay. The guidelines said you have to wait for fractures in normal children, but a child with high-risk problem like cystic fibrosis, inflammatory, I would start specific treatment. I will do, other measures, optimize the vitamin D intake, avoid steroids, and so on and so on.
Michael. The last question.
Thank you, Adnan. Thank you so much. Just a small comment for our dental pediatric. The biphosphonate mechanism of action, it decrease the calcium or take the calcium from the blood to the bone. So that's why very important to check the parathyroid after we give the medication, because they will have hypocalcemia. So the calcium is very important to be given even after the patient take the biphosphonate for at least 10 days. You'll be in the safe side, because there will be secondary hyperparathyroidism. And for any patient having biphosphonate and it develop fever during the admission, this sometimes which is normal, so don't take a blood culture on these things, because of that. This is one of the side effects or common side effect of lendronate or biphosphonate.
Good point, Dr. Abdullah. Because of the time, I did not mention that the guidelines, or the protocol we do, we give calcium and vitamin D high doses 1 week before and 1 week after the zolidronate infusion. So this is a protocol for all our patients.
شكرا Professor Adnan, and now we end the session, and I will give the mic for Dr. عبد الحفيظ.
نشكر الرؤساء هذه الجلسة، ويتفضل الدكتور عبد العزيز التويم رئيس المؤتمر بتكريم الرؤساء. الدكتور خالد بواكد، شكرا دكتور خالد، وايضا الى سعاده الدكتور عبد الله البنيان، عبد الحميد البنيان. هنالك تنويه مرة ثانية، عفوا المتحدثين أيضا. دكتورة تفضل معنا، خليك معنا في التكريم. دكتور عبد الحميد تفضل معنا. تكريم للدكتورة نجية عطية. والدكتورة هيفاء الفرائضي. تفضل الدكتورة هيفاء.
شكرا. نشوفك بعد الظهر ان شاء الله.
شكرا بارك الله فيكم. وقبل ان نبدا الجلسه التاليه، هنالك تنويه مره اخرى الى اننا جاهزين بالباص موجود امام المدخل اللي الرئيسي ده لاداء فريضة صلاة الجمعة إن شاء الله، والعودة مباشرة لتناول الغداء، ونكون هنا في القاعة 1:15. سنبدأ مبكرين إن شاء الله. أيضا في نفس الوقت نود أن ننوه بأن هنالك Diabetic Education and Dietitian Symposium موجود في القاعة تبوك المجاورة لمطعم الفردوس، فالمهتمين والملتحقين بتلك الدورة يكونوا في قاعة تبوك قرب مطعم الفردوس من الساعة 2 وحتى 4 إن شاء الله. نبدأ الجلسة التالية، ويسعدني أن أدعو سعادة رئيس الجلسة الدكتور عبد الله الشهراني ليبدأ هذه الجلسة. وسعادة الدكتور معروف بأنه he is a consultant in the pediatric endocrinology in Armed Forces Hospital, Southern Region, Abha Private Hospital, and he is the head of pediatric and pediatric endocrine section, Abha Private Hospital. أتفضل دكتور.
Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh. We'll inshallah start our section now. We'll introduce a well-known colleague, Prof. Amir Babakar, MBBS, United Kingdom, FRC, BCH, United Kingdom, CCT, UK, MSc Endocrinology and Diabetes, Consultant Pediatric Endocrinologist, Associate Professor,
in King Saud bin Abdulaziz University for Health Sciences and King Abdullah Specialized Children Hospital in King Abdulaziz Medical City, Riyadh, and Ministry of National Guard Health Affairs. Dr. Bakr.
Thank you very much for the introduction, and thank you for the organizing committee for inviting me to give you a talk about this very interesting topic. First to benefit from preparing for this one, which is a very debatable topic. It's about the role of glucagon-like peptide 1 agonist in the type 1 diabetes. And the agenda of my talk includes why do we need new treatment for type 1 diabetes, and the role of incretin hormones in glucose homeostasis. Then I will talk about some literature on the use of GLP-1 in type 1 diabetes, some RCTs and meta-analyses, and a real life experience. And I will finish by some future perspectives. We all know that when we treat patients, that the glycemic control is lost over time, whatever technology and advanced therapy you use. And also, you don't achieve good glycemic control unless you have this in the expense of hypoglycemia. And sometimes with intensification of insulin treatment, we have the weight gaining, which turn over to result also in insulin resistance. So this is one of my patients, as many of your patients as well. Obviously, you can see that in order to have a mean reasonable glycemic control with some intermittent high glucose excursions, you need to have multiple hypoglycemias in order to go there. This is one of our studies as well, also demonstrating that even with continuous subcutaneous infusion, you have the glycemic control, and the willingness of the patients to get engaged in good therapy and further improvement of A1C is lost over time. And also, as you can see, comparing the pumps to conventional therapy, this results in more weight gaining. Obesity is pandemic, as you heard earlier from Dr. Haifa this morning, and this put more of risk of developing type 2 diabetes on children. In addition to that, our current treatment of subcutaneous insulin is really not meeting the expectations. So what's happening there? It's not meeting the expectations because we have a lot of advantages of subcutaneous insulin, but also we have disadvantages because peripheral insulinemia is not really pouring into the hepatic portal system. And the limitations of pharmacokinetics of available insulin result in all these risks of postprandial hyperglycemias, hypoglycemias, and excessive weight gaining and insulin resistance. So these limitations make people think of future directions for therapy. So people work more on immune manipulation and modulation, and also on optimizing the subcutaneous insulin action and delivery. So these are all different modalities used and gaining a lot of interest. So many places, for example, looking for cheaper types of insulin, the biosimilar insulins. People work on more of physiological delivery that mimics normal delivery of insulin in the body, so in forms of artificial pancreas, and also, as I mentioned, immune modulation, working in induction of the immune tolerance, and also reduction of beta cell injury and toxicity, and inducing beta cell growth are very popular topics as well as stem cell derived beta cells. So if you think of hyperglycemia, there are multiple reasons for this in patients with diabetes, postprandial and in different situations when they have weight gaining and lipotoxicity. And if you think of incretins, the incretins almost playing 50% of roles in reducing these risks of hyperglycemia. If you think of them in their work in the GI system, in the insulin secretion, in the glucagon, suppression of glucagon secretion and control of appetite, these are all very useful, promising functions of incretins. What are the incretins? Okay, so orally ingested glucose levels induce much higher insulin response than IV glucose. This is the incretin response. And this comprises 60% of the insulin secretion in the body. And the two famous and main incretins in the body are GLP-1 and the glucose-dependent insulinotropic peptide, which is called GIP. So these are secreted from this jejunal and duodenal cells as well. So two different jejunal cells, the K and the L cells, are the main secretors of GLP-1. And they are secreted in response to food intake. And as I mentioned, their main function is to induce and stimulate insulin secretion and reduce the glucagon secretion. But they also have other benefits of regulating gastric emptying and feeling of satiety and fullness. And by this, they can also control energy intake and reduce weight. So they have a lot of desirable effects on different parts of the body. And this can be summarized as efficacious glucose lowering through the insulin and the glucagon control, and also the gastric emptying and the beta cell stimulation, which is demonstrated in animal models. And the second is body weight lowering through the control of gastric emptying and the satiety, as I mentioned. And the third is also a potential halt of the disease progression by controlling the beta cell toxicity, as has been demonstrated in some animal models. There is a problem in handling the GLP-1 in the body, because there is an enzyme, which is the dipeptidyl peptidase, DPP4. This reduces the native function of the GLP-1, so reduces the function of it. So how can we tackle this pharmacologically? There are different types of incretins. One is simply DPP4 inhibitors, acetagliptin, valdegliptins, and all these ones. And obviously, this has got less effect, potent effect than stimulating the receptors as by the GLP-1 receptor agonists. And these are of different types. We have one extracted from the salivary glands of lizards in South America. These are the exenidine ones. It's known exenitide or Byetta. And we have the factory manufactured ones or lab manufacturers, the liraglutide or Victoza. And we have the new ones, the DPP4 resistant analogs like exenitide, etc. And as I mentioned, it's expected that the GLP-1 receptor agonists have more potent effects than the DPP4 inhibitors. There are at least 6 famous forms of GLP-1s in the market. The most famous of them are semaglutide, liraglutide, and exenitide. And they do work at different stages of the disease. As I have mentioned earlier, in the early diabetes, they can reduce the toxicity on the beta cells, and later on they can work on the insulin glucagon pathway and also the satiety center, reducing the weight, and by this helping the insulin resistance and response to insulin in type 1 diabetes. So this one summarizes different physiological effects or different stages of the disease. And as you can see, GLP-1 is involved in this early stage of relieving the stress from the beta cells and stimulating the remaining ones, as demonstrated in animal models, and also reducing the metabolic consequences of having insulin in terms of insulin resistance, and also building on body weight. So if you think of all these pathophysiological physiological effects of the GLP-1, they result in these outcomes that are used as endpoints in RCTs to monitor the effect of these GLP-1s. These are insulin resistance, body weight, blood pressure, blood lipids, and blood glucose, as we will see in a minute in these RCTs, which is the third part of my presentation. So these are the two famous largest RCTs, which are adjunct 1 and adjunct 2. And these include 1,300 and the other includes 800 patients, and both are published in Diabetes Care. But there is more recent meta-analysis that includes these two studies and includes other also similar smaller RCTs. And the title of that was Glucagon-like Peptide 1 Receptor Agonist as Add-on Therapy to Insulin for Type 1 Diabetes Mellitus. Can I go back to that slide, please? Yeah, in this meta-analysis, the conclusion was that GLP-1 receptor agonist, as you can see, the bottom of the results, actually they increase the incidence, they do not increase the incidence of severe hypoglycemia, although they are known to cause hypoglycemia and more detection of ketosis, but they don't increase the incidence of diabetic ketoacidosis or severe adverse events. However, there is apparent GI side effects with GLP-1 use, especially nausea, and this is more apparent in children. We'll see that in the meta-analysis done in children. So these are the studies included in the meta-analysis. As you can see, the second and the third are the adjunct 1 and 2, and they are all adult studies, and they all run about 1.5 to 2 years and showed significant improvement in the metabolic parameters of type 1 diabetes patients with the use of GLP-1. And as you can see there in the second column, they use the meta-analysis included different types of GLP-1 agonists. So this is a summary of these RCTs in this meta-analysis. As you can see on the top right-hand corner, that A1C is significantly reduced, and as well as the mean blood glucose, as well as the mean glucose excursion, and also the total insulin dose, as well as the prandial and the basal insulin have been significantly improved. And also the systolic blood pressure. So these are all the markers and marked reduction of weight. And the conclusion of this meta-analysis is that they suggest moderate, the RCT suggests moderate beneficial effect of GLP-1 receptor agonists on the metabolic profile in patients with type 1 diabetes without an increased risk of serious adverse events. So this is a real life experience one. So this study has been published last year, 2023, and the cohort included 53 or 54 patients, and it ran for 1.5 to 2 years, and it included number of GLP-1 agonists, and demonstrated clearly that there is improvement in A1C with the use of GLP-1 therapy, and also increase of time in range by 12%, and also reduction in time in hyperglycemia, and also reduction in the DKA hospitalization with a marked reduction in weight. And this is a first live experience documentation. However, it needs more additional prospective studies. So what happens in children? So in children, in 2012, pediatric diabetes, it has been published that proinsulin and GLP-1 are high and glucagon is low in patients in remission, partial remission phase. And this clearly indicates that they have beneficial effect in these patients. And the safety and efficacy of GLP-1 in obese children and adolescents has been well demonstrated in this large meta-analysis, including more than 500 children. And this demonstrated, obviously, that they have a modest effect in weight and BMI and glycated A1C and blood pressure and all the markers of metabolic syndrome. However, they have increased rates of GI side effects, especially nausea. And this shows the improvement, a marked improvement in the forest plot in A1C and fasting blood glucose, but also the apparent side effect of nausea, which is a usual cause of discontinuation of this therapy in these children. This is an interesting local experience from Bisha and also from Jazan, Riyadh, and with collaboration with colleagues from Liverpool. They published this review article on using GLP-1 in children, and they concluded that this function is well established in type 2 diabetes, but not yet in type 1, and this pancreatic beta cell improvement is experimental still in animals, so there is no consensus as yet of using it in children, and it has to be on an individual basis. This brings me to the last final slides. Insulin remains a mature therapeutic cornerstone of treating type 1 diabetes, but our understanding of type 1 diabetes is continuously evolving, resulting in more novel prevention and management strategies. The immune suppression and manipulation strategy is only partially successful, so we need to work more on the beta cell rescue strategies such as GLP-1 agonist and others, which are proven to have beneficial effects in adults with no serious side effects and beneficial effects in adolescents. As we talk, we are in the situation where Henry is, so we are not quite sure. But what to do next? Obviously, we accept what's existing and what's available of the treatments, and we accept that we may have some metabolic changes with the use of these medications. We need to stay vigilant in dietary management and education of patients, and also in prescribing smaller, effective, but not toxic medications, and we need more RCTs to have more conclusive results and consensus. Thank you very much for listening.
Thank you. Thank you very much, Dr. Amir. I think we have just time for 2 to 3 questions. Thank you very much. Okay, and we'll okay. Recognition to Prof. Amir. Now, you know all Dr. Prof. Bassam bin Abbas, our figure and our colleague. He is a consultant head section of endocrinology and diabetes, King Faisal Specialist Hospital and Research Center, Riyadh, Professor of Pediatric Endocrinology in Al Faisal University, part-time consultant endocrinology and diabetes in Royal Clinics of Custodian of the Two Holy Mosques, Private Affairs from 2018 till current, part-time consultant endocrinology and diabetes, the complex of the International Diabetes Center from 2021 till current. Dr. Bassam.
طيب بسم الله الرحمن الرحيم. First, we'd like to thank the committee organizing this conference led by Dr. Abdelaziz Touaim. And I hate to start my presentation by apology. And the reason I'm saying that because I missed the first day, which was yesterday. Although I'm just not a speaker, I'm a member in the organizing committee. And the reason behind that, there is a reason behind that because yesterday we spent the whole day in Winter Garden. And I would like to thank the General Authority of Entertainment for inviting our children with diabetes. We managed to have like 300 children with diabetes with their families. And this is Dr. Al-Banyan, cousin of Abdelhamid Al-Banyan. And the good thing about the General Authority of Entertainment, they admitted our kids with diabetes like half an hour before gates open, so we had a time to enjoy the dangerous, let me call it, rides, including Qatar al-Ra'b. And this is a post by His Excellency Turki al-Sheikh talking about this visit to the Winter Garden. And while we are just at the top of one of the big rides in Wonderland, we have to thank His Excellency. And this is what we wrote for him just before the big drop in the largest coaster. And you can read it. نحو العلا همة الأطفال ماضية يستشرفون ذراها لا يهابون لأنهم رفعوا رايات موطنهم بعزة حين قالوا سكريون أحبنا الناس ما أحلى مسيرتنا وقادة العز إكراما أحبونا وحسبنا هيئة الترفيه راعية تسعى بظل معالي الشيخ ماضونا أطفالكم طاقة من همة صمدت أما جميل احتواء يستحقون. So I'll start my talk by trying to answer this question. Does new technology improve diabetes care in children? And because the time is so limited to 20 minutes, I changed the question which was given for me to answer to this. Does new technology improve diabetes care in Saudi children? So my talk will be restricted to Saudi children, and I will go over the Saudi local published studies trying to answer this question about technology and diabetes care. So there are 3 or 4 topics I would like to go over it quickly. Number 1, the mobile phone applications and continuous glucose monitors, insulin pump therapy, and artificial intelligence. And by the way, last month, we had a big conference about AI in transforming diabetes care in Saudi Arabia. So these are I call it the innovative diabetes care models in Saudi Arabia. So we'll start by the mobile phone applications. It's well known that there is a big gap in our care, and the traditional solutions for managing or keeping down these diabetes epidemics didn't work because the incidence and also the prevalence of type 1 and type 2 diabetes are increasing. So maybe technology can help us in improving the communication defect between us as healthcare providers and our patients, and mobile phone applications could solve the problem. So there are 2 ways of doing things. There's a traditional care by having more diabetologists, more nurse practitioners, diabetes educators, more clinics. And there is another way with the help of technology to improve things by proper utilization of technology, by having more phone clinics, virtual clinics, and other tools of e-health. I will start by talking about the mobile health technology, which provides educational knowledge through messages. And nowadays we have mobile phone applications can do the same job for various needs. And also call center, having a call center like 24/7 definitely will help our patients for 24-hour consultations. In the past, we were reluctant to use e-health tools, but what we learned from and COVID pandemic, that these ways of communications do help our patients, like having video conferences, like phone calls. And during the COVID period between 20 and 21, as you can see in this figure here, almost all in-office visits were replaced by video/phone visits. Not only that, funding, the digital health funding also peaked up during that period, and still a good amount of fund is going towards digital health care. This is a paper, we did it with Dr. Abdullah Al-Faris long time ago. So we were ahead of this technology this was published like 7 years ago, talking about the effect of a mobile phone text messages on glycemic control in type 1 diabetes. And just by providing educational messages to our children, all parameters did improve, including the postprandial blood glucose, fasting glucose level, and positively affected the A1C, and dropping it by almost 0.5% in only 6 months. Not only that, compliance with therapy like insulin injections and blood glucose monitoring did improve by these educational messages. The knowledge also improved among these patients receiving these educational messages. Also, we duplicated and replicated this study in type 2 diabetes, and we got almost the same results. All parameters did improve, including hypo and hyperglycemic attacks, and also the average A1C and the knowledge as well. So SMS, which is an old way or service provided by mobile phones, did help our kids with type 1 and also type 2 diabetes. So what we concluded from that study, which was published 7 years ago, as I told you, the telemedical education support using mobile phone text messages offered a means of contact between clinics. We're not talking about complete replacement of the traditional clinics, but we are talking about adjunctive way of helping our patients. Nowadays, we have a good number of Saudi mobile phone applications like Karas, for example, like what's called NCARB, which was replaced to Ethnain applications, but also we have LAN Care, we have Sanar applications. All these applications connect patients with diabetes with a medical coach, with educator, with dietitian, and providing remote consultations, including carb counting educations. It's like the remote diabetes coaching applications like the Blue Star, Lark, and Livongo, and others. And these applications in general, they are trying to close the gaps in care by providing real-time support and expert coaching. Some of these applications, they can track your appointments, your blood test, your routine exams as well. And some of these organizations, let me call it, did publish their results. Look here, by lowering A1C almost like other medications by 2.3%, and also the blood pressure and weight as well. There are several studies talking about that, about the mobile phone applications and improving glycemic control. This is a systematic review, included 14 randomized trials, and this is another study including 50 systematic reviews. All these studies, including this one as well, which is a recent one, by the way, showing the effectiveness of smartphone application-based self-management. And this is, by the way, one of our targets in the Ministry of Health, الصحة الإلكترونية هي أحد أهداف رؤية 2030. And here in Saudi Arabia, the Ministry of Health has two applications like صحة and صحة الأطباء, and both of them providing free consultations among patients and between also physicians. And as you know, 2 years back, or maybe 1.5 years back, Saudi Arabia launched its first virtual hospital in the Middle East, and over 130 hospitals across the kingdom cooperated to establish this hospital. And so far, they are providing like 34 services, and they are aiming to serve 500,000 patients remotely. And I think the virtual hospital fits our needs as a diabetologist, because we are the one who are interested in telemonitoring, telecare, teleconsultations, and also telehome care. I will move on because of the time limitation to the second innovative diabetes care models in Saudi Arabia, which is the continuous glucose monitors. And we have in Saudi Arabia three types or devices. We have the Freestyle, the Guardian, and also the Dexcom. And the best feature of these continuous monitors is their ability to share data with your healthcare providers. And quickly, I would like to go over some of the published papers here from Saudi Arabia talking about this technology. This is by Dr. Al-Harbi, which was published last year or 2 years back now, measuring the impact of flash glucose monitoring in our pediatric patients. And as you can see, this is the first study which included the largest series and cohort of patients, almost 1,500 patients, and showed for the first time a big drop in A1C from almost 11 to 9% within only 9 months. There are other published papers as well. This is by Al-Hayek from the military hospital, showing the frequency of DKAs among patients using freestyle Libre. And as you can see here, there's a big drop in the frequency of diabetic ketoacidosis over 6 months. This is another study by Dr. Hayeka as well, showing the same thing about the quality of life of these patients, like the worries and A1C, all these did improve by using the continuous glucose monitors. Moving to the fourth innovative diabetes care models in Saudi Arabia, which is the insulin pump therapy. We started our first pump in year 2000, I think, and we recently submitted our data to the conference called the TDD, which will be held in Italy, on 70 patients using tandem IQ, and the majority of them, maybe 80% of them or more, having a time in range around 80% or more. This paper by Dr. Amir Babikar, I decided just to present for you some of the recent papers on insulin pump therapy. This was published last year or maybe 2 years back now, talking about the effectiveness of pump therapy versus multiple daily injection of insulin in type 1 diabetes. And there is a clear difference in A1C between the two modalities of intensive insulin therapy, as you can see here. And also there is another paper by Dr. Adnan al-Sheikh, also published in 2022, talking about the quality of life in children using pump therapy, comparing them with multiple daily injection of insulin and showing the same thing. Let me focus on the worry problems, much less in patients using pump therapy versus MDI therapy. Another paper also by Dr. Nickbel here, she looked at the impact of insulin pump therapy on a large number of patients, 200. Maybe this is the largest series here. Some of them were in pump and some of them were in multiple daily injection of insulin. She showed the improvement in efficacy, but also she showed also significant improvement in hypoglycemic attacks and also diabetic ketoacidosis. This is a recent paper, by the way. Also, I can mention the names of pediatric endocrinologists in this paper, which was led by Dr. Mohammed Al-Sufyani. I can see the name of Dr. Mohammed Al-Harbi and Dr. Abdul Mu'in Al-Agha, and included almost 500 patients, and talking about Ramadan using Minimid 780. And as you can see here, that the timing range around 80% during the day, it dropped during the night to 60%. But again, this gives us indication that patients or adolescents who are interested in fasting Ramadan, they can do that by using these automated, let me call it, insulin pump therapy. So the time below range was about 2.3%, not very high, and the time above range less than above the target, which is 18%. By the way, since we are talking about the technology, if you remember that we had a conference like 2 years ago, also at that time, I invited Dr. Nwaid Al-Zaman and Dr. Mohammed Al-Sufyani, talking about what's called the do-it-yourself pumps, or using the recently approved FDA application called Loop application. At that time, I remember that the number of patients using this technology is around only 116. But now I was surprised because I joined the Telegram recently. It's called Al-Halaq Al-Mughlaqa, and I found around 600 patients using this kind of technology. So what I'm trying to do, just to send them a survey, just to know what's the percentage of them having A1C within the acceptable range. But based on the initial input from these patients, I think the majority of them having an A1C between 6 to 6.5%. So last but not least, just because of the time limitation, I will talk more about the artificial intelligence in the diabetes educator course. But as I told you, we had a big conference about AI in and its effectiveness in transforming diabetes care. We did talk about the diabetes or diabetic retinopathy diagnosis, risk modeling, and also self-management using mobile phone applications, advanced genomics and precision medicine, and of course, the automated insulin delivery. By the way, number 3, which is the mobile phone applications, you may say this is not AI, this is just a modality of e-health. What is interesting that the STC recently contacted one of the companies and was involved in that. They're trying to make an application with automated answers. Now, no, the AI is basically it's the learning data. So they are trying to collect a large number of questions and answers, and they are trying to deliver the answers automatically for any questions. So this is a
5
source,
minutes, Dr. Bassam.
So this is a source. This is a type of AI technology. This is, by the way, I decided just to talk quickly about the AI and diabetes retinopathy. And if you can read the second paragraph, many AI algorithms have achieved good sensitivity and specificity, more than 85% for detecting diabetic retinopathy compared with the human graders. So this is very interesting. And this was published, by the way, recently in Diabetes Care under this title, AI and Diabetic Retinopathy Framework, Prospective Studies, and Head-to-Head Validation, and also cost effectiveness. Our ex-chairman, for ophthalmology, Dr. Salwa Al-Hazza, after her retirement from King Faisal Specialist Hospital, she launched this company called SEDM, and so far she screened more than 36,000 patients free of charge using AI technology. So back to the question which was given to me to answer, does new technology improve diabetes care in children, particularly in pseudochildren? The answer is yes. And if we go back to the ADA and their recent publications in diabetes care, it states that diabetes technology, when coupled with education, follow-up, and support, does improve lives of people with diabetes. And for more information about AI and diabetes care, I would like to invite you to attend my talk in the diabetes educational workshop. And again, I told you like 1 month ago, we had a big conference in Arabic about AI and diabetes technology, and the attendees, they like it. And their response to us was very positive about our talks and our discussions. And I can show you, this is the response for our patients who attended our conference. I can read it for you. في هذا اليوم مشاعرنا باعثها نبض قوافينا أطفال السكر قاطبة قد رفعوا الشكر ميامينا في زمن جاد بتقنية مجدية فينا تكفينا فهناك ذكاء مصطنع قد يوجد حلا يرضينا وجهاز يتطور بدلا عن بنكرياس يغنينا ها هم صناع تطلعنا صاروا بالهمة ساعين ما فتئوا بحثا وجهودا في كل جديد يثرينا فالشكر توالى عرفانا لأياد ترعى آتينا ترعى مستقبلنا ثقة بالله رأيناه يقينا شكرا يا وطنا أذهلنا بشموخ فاق أمانينا في كل مجال يدهشنا ولرحب المجد ينادينا زفي يا مملكة العظمى بشرانا وافتخري فينا. Thank you.
صح لسانك يا أبو. Thank you very much, Dr. Bassam. We have just 2 or 3 questions. Now just we'll ask Dr. Bassam.
Can I have a question?
اوكي دكتور عدنان.
Thank you, Prof. Bassam. Very interesting talk and a lot of technology. I'm sure it will help diabetes care. But let me ask you, Bassam, do you have an experience with the virtual diabetes clinic? I mean, not during Corona, after Corona, currently. I mean, if you have like a physical clinic and another virtual clinic, what's your experience with that?
Yeah, okay, actually, what we learned from, what we learned from COVID, that virtual care is very effective in providing the best care for our patients. So this is the trend now and the direction of our hospital to, for every physicians to have a virtual clinic. So myself, I have one every month. My colleagues, they have maybe more than once, maybe weekly. And it became one of our KPI indicators, by the way. So to answer your question, yes, we have maybe 5. Okay, very good. Explain very good, because I mean, patients love it. And also this will reduce the number, especially at King Faisal Specialist Hospital as a tertiary care center. People are coming from all over the kingdom to us. So by having these virtual clinics and phone calls as well, reduce the number of travel for our patients from their small towns and cities to Riyadh.
Bassam, and thank you very much. Very good. And Dr. Babakar is really excellent talk. Just to comment, I think, you know, the pumps and the technology is becoming like a standard of care everywhere in Europe and the States. And the problem, we are lagging behind in supplies, in who will buy the pumps, who, you know, give the children the pump, the, you know, luxury of having these monitors. You know, is there any way of, you know, make it universal care in the kingdom? I mean, you people interested in diabetes technology should have the recommendations to have this as standard of care. Nobody will be on needles anymore. So I don't know what's going on in that way.
Well, we had several meetings مع المجلس الصحي السعودي. The last one led by Dr. Saoud Al-Sifri in Riyadh, by the way, in Crown Plaza. And we have the guidelines, we have the recommendations, and it should be applicable for any patients, which is if his physician recommended for him a pump therapy, it should be approved quickly by the insurance company. But still, things are not going in the right way. That's why Dr. Saoud Al-Sifri asked for a meeting, and also في المجلس الصحي السعودي, and we are trying to accelerate things, make it more easy. I'm not working in the private sector, but what I heard from my colleagues who are working in the private sector, things are much better than before.
Just a comment on, I think as shown by the guidelines yesterday, Dr. Sani Aweda, CGM, continuous glucose monitoring for type 1 is a must. It should be for every type 1 diabetes. Now, pump should be or not, I think it's a technology, expensive technology, and you can still give the basal bolus therapy by the MDI. It's so expensive. I mean, we cannot really put a lot of cost on our health economy that it should be given for every patient. But CGM, I think it has to be available for every patient.
And it's approved by the insurance, طيب? Approved by the insurance?
Yes, I think in most, but I mean in the government, it has to be, it is a must. It should be.
Sam, just a quick question and quick comment. With this advanced technology, what's your sincere advice to doctors at all sectors as expert physicians and general practitioners, how to cope with this technology and what sort of collaboration we should have with pharmaceuticals to teach ourselves about all the details of this, because we need to have some at least similar knowledge to what our patients have to be able to manage them?
Yeah, it's as you know, Dr. Amir, and I'm sure that my colleagues know it very well, that is time consuming. Having the CGMS, having the data, having patients on a pump therapy, this is very time consuming in the clinic. Part of it should be dealt by the physician and part of it by the diabetes educator. So hiring more and more expert diabetes educators definitely will help us. And having virtual clinics, phone clinics, we have at King Faisal Specialist Hospital, we started 2 clinics. We called it digital clinics. So every week we have 2 clinics, digital clinics. 40 patients were booked in these clinics. So we are communicating with our patients because things are can be done remotely. The data from the CGMs, the data from the pump therapy can be downloaded. So what we are doing in the digital clinic, we are downloading the data. We are communicating with the patient every week. So for that reason, our data was very good and on 70 patients on Tandem IQ. The results will be presented, inshallah, in the ATDA in Florence, in Italy, inshallah. The collaboration is very important between dietitian, between physician, between diabetes educator, and things. I think we can cope with this. The technology was made to help us, and we should utilize it in a proper way.
Thank you very much. Thank you. Just recognition for Dr. Bassam.
نشكر متحدثنا الفاضل البروفيسور عباس بن بسام، الذي دائما أنا أصفه بأنه الطبيب الإنسان ذو المشاعر الجياشة والشاعر أيضا، كما نكتشف في كثير من محاضراته عندما يتحفنا بكلمات تمس موضوع المؤتمر وموضوع الندوة التي يشارك فيها ويقدمها. شكرا لكم جزيلا بروفيسور، وهذا تقدير من اللجنة المنظمة. شكرا. كما نشكر سعادة الدكتور عبد الله الشهراني رئيس هذه الجلسة على رئاسته الممتازة للجلسة والحفاظ على وقت الندوة المحدد. شكرا، بارك الله فيك دكتور عبد الله. شكرا. الآن إن شاء الله طيب، ما أدري والله، في اقتراح أساتذتنا، طالما عندنا كمان يمكن 2-3 نقدر ناخذ صورة جماعية تذكارية، قد لا تتاح بكرة السبت، يمكن البعض منكم يسافر. تحبوا تحت، تحبوا فوق، صف ثاني، نقدر ناخذ من البروفيسورات والأساتذة الأجلاء. يلا. ترى حتى المتحدثات الأفاضل، اتفضلوا، من ترغب انها تشاركنا في التقاط هذه الصورة التذكارية فلتتفضل. هذه وليدة لحظتها الفكرة دي. اي يلا هنا. طيب انتوا دكتورة خيرية تفضلي. دكتورة قزاز تفضلي. ترى زميلاتنا الأفاضل يعني نتشرف بأنه تكون هذه فرصة لالتقاط صورة تذكارية لهذا المؤتمر. خد الجوانب ترى في ناس في اليمين واليسار. في حد ثاني يفكر يبغى ينضاف الينا؟ يا شباب ايش بكم قاعدين ما تيجوا؟ دكاتره. ايوه كده. دكاتره ليه ما تتقدموا؟ ترى ممكن ناخذ صوره، انتوا تاخذوا صف امامي مش صف خلفي في المقدمه. هي استاذه عشان تشجعي الطبيبات. ونعدكم بأنه هذه الصورة إن شاء الله ستصل إلى إيميل وواتساب كل واحد منكم إن شاء الله. هي خلاص الباص في أمام البوابة الرئيسية أمامنا على يسار البوابة، وسنعود إن شاء الله 1:15 لنستأنف البرنامج العلمي والجلسة اللي بعد الظهر إن شاء الله.
Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. in addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision, Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion, in addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others. We, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision, Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision, Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, The Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. in addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, The Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision, Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision, Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, The Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision, Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision, Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies
schlecht sein jetzt. Aber ich kann mir das anschauen und dann gucke ich mir die Werte
and its
an. Wie hieß
topics
die?
up for discussion,
Also-
in addition to their interests in awareness and health education for patients,
Ich schaue noch mal schnell rein, damit ich da jetzt nichts Falsches sage. Sagen Sie mir noch mal den Namen. Das
as
ist
organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement.
25. Mai 23. Ich schaue schnell durch und dann melde ich mich. Ne? Bis dann. Tschüss.
Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. Ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement.
وقاعد أخذ عنده
شايف لك هالمناصرة
أحمد آثر معلم الشغل الصمصومة هيك كل موظف جيب لك إياها باللابتوب الصغير شو بدك تنزل معلم راد وقصص وعنده حكايات قلت له قال لي هذا من فوق أنت شايف فوق هاي المرة يلا.
Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by a branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the vision. Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please.
جاهز؟ السلام عليكم ورحمة الله وبركاته، وأهلا وسهلا بكم ومرحبا في مؤتمركم وفي اليوم الثاني من فعالياته. والآن نبدأ الجلسة السادسة من جلسات المؤتمر والثالثة لهذا اليوم، وأتشرف بدعوة رئيس الجلسة سعادة الدكتور عبد العزيز التويم. Dr. Abdulaziz Al-Tuim, he's a well-known consultant pediatric endocrinologist and associate professor, vice president of the Saudi Pediatric Association, and he is the chairman of our conference. Dr. Abdulaziz. Bismillah.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. Would like to welcome you again in this conference. Our speaker, due to the prolongation of the Jum'ah prayer, الإمام جزاه الله خير قربنا خطبة طويلة شوية وكان في تأخير بسيط. We'll start with دكتورة نجية عطية. Dr. Najia Atiya is a consultant pediatrician and pediatric endocrinologist at King Abdulaziz Medical City National Guard in Jeddah, and she is associate professor in the Department of Pediatrics, College of Medicine in King Saud bin Abdulaziz University for Health Sciences in Jeddah. She is also held a lot of position as the director of training program and also as the training residency program So she is going to talk about growth hormone, shedding on growth hormone deficiency. Dr. Najia, thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Twain, for a nice introduction. Okay, I will start actually with okay. So I will start with just a little bit history of growth hormone. And we can imagine that before like last century in 40s, the hormone coming from pituitary human growth hormone extracted in last century and started to be used for human being in 1958. But the amount at that time, it was very little. One pituitary was enough only for one dose and for one patient. Because of that, the strategy was just to give this growth hormone for profound growth hormone deficiency children, and only to treat children for 6 to 9 months per a year, just to permit others to use growth hormone, and to continue on such a strategy until 1980, when the decision was taken to stop using pituitary human growth hormone, because it comes very clearly that Creutzfeldt-Jakob disease transmitted from the brain tissue. And because of that, they stopped using pituitary human growth hormone. But we were lucky, because just 1 year after, in 1981, the growth hormone DNA recomponent become available and approved first to be used for children with growth hormone deficiency in 1985. And with time, it approved to use for many causes of non-growth hormone deficiency, growth disorders, with unlimited supply. So this is just little bit history of our growth hormone. But as you know, we are all the physician, we know that all the consensus and the guidelines recommended us and even requesting us to start growth hormone therapy for all patients with growth hormone deficiency. And why we have to do that? And because to promote growth, and I hope this time it will work. So this is the main goal of it, to accelerate growth to reach to normal adult height. And this is all recommendation, but they also recommended us to monitor our patients, to monitor the response to growth hormone therapy. And this is very important, why we have to monitor our patient response to growth hormone, to avoid, it is not work. Takes time. Okay, why? To avoid actually prolonged ineffective treatment and inconvenient, unnecessary cost and possible side effects. So it is important, once we started patient to growth hormone, to monitor the response to our starting treatment. The challenges we are facing usually in treatment of patients with growth hormone deficiency, the lack of the response to growth hormone therapy, and this is very important challenges we facing. So how we can monitor or assess our patient or identify the patients that they are not responding to growth hormone? There are some tools we can use or not using, but at least available. For example, the prediction models like Gussenberg and Kekes. This is models already approved and already validated to monitoring our patient response to growth hormone. And it is really very useful because it gives us an idea about the response to the treatment and also estimating and the anticipated effect of growth hormone. But unfortunately, we cannot use these tools in our clinical setting because it needs a special calculation and calculators which it is not available. So we cannot use it. So what about biochemical markers like IGF-1 and binding protein 3 to use it to monitor the response of our patient to the growth hormone. Okay, we can use it, but again, it is not validated to be used as a monitoring for response. And we have to know a few factors about it, that the levels usually are affected by many factors, and also because the response vary greatly and with short-term change. So what about IGF SDS? Okay, we can use it also. It gives us a standardized score for the patient IGF-1 levels, which can be compared to the reference population. But again, it is not validated to be used to monitor the response. Some propose that we can use the bone matrix to assess the response to growth hormone, like the alkaline phosphatase, pro-collagen, but again, we cannot use it in our clinical setting because we don't have a cut-off value, and also because it is not validated. So we left actually with only measurement. And this is the criteria on it we would depend to assess our response to the growth. So either to see if the height velocity less than 3 centimeters per year, so this is a poor response to the growth hormone, or if the height velocity SDS less than +1 SDS, or the delta height is less than 0.3 or 0.5 SDS. And what we mean by delta height, it is the difference between the height SDS at the beginning of the treatment and at the subsequent time points. This figure, it just shows us the concept of growth hormone treatment through the lifespan, and it shows us that it goes through 4 phases. The first phase, the catch-up phase, when the accelerating the growth rate by growth hormone to reach to the maintenance phase when the growth velocity reach to normal growth velocity, then puberty with growth spurt, and adulthood phase when the height close to the target height. And all the literatures, a lot of literatures found that the assessment at the first year or response of the growth hormone after the first year of treatment correlated significantly with the gain in adult height. Because of that, the recommendation to assess the response to the growth hormone after the first year of treatment. This study actually done, it was the first study done to know or to identify the percentage of poor responder to the growth hormone therapy after 1 year of treatment. It done actually in good number of the short prepubertal children, 456, and they actually found that when they use definition, when in case of isolated growth hormone deficiency, when they use the definition of delta height less than 0.5, they found the percentage of non-responder reach to 28%. And when they use the definition, the height less than, the height less than 0.3 centimeter, the percentage increased to 38%. And also in organic growth hormone deficiency. And in the small for gestational age, we reach up to more than 40, and 40% in idiopathic short stature, and internal syndrome and other syndromes, the non-responder to growth hormone, more than 50%. So actually we have a significant number of non-responder to growth hormone therapy. And we need to understand the factors contributed why our patients, they are not responding well to growth hormone therapy. And this is a systemic review and data analysis of 13 studies, and they included more than 2,800 children in growth hormone. And they found that non-adherence to growth hormone, it reached to, excuse me, can you concentrate with me, please? Because, okay, no. Okay, and they found that the prevalence of non-adherent to medication, it reached from range from 5% to 82%. So this is non-adherence, the prevalence. It is very huge percentage, and maybe non-adherence to medication could be a contributed factor to non-responsiveness to growth hormone therapy. And to prove that, the study done, no, not this. The next one. Oh, what? I am not lucky today. All the slides, even the second lecture, it is. We finish from this paper. Sorry for this technical problem, and well, you have to move it. Dr. Khoja. I don't know, Dr. Twaim, if you want the other speaker to do till they fix the problem, or خلاص, it is okay. ايوه انا حاولت لك يا مراجعتك. لا عشان يجي الدكتور الثاني على ما
Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone to support it. Our conference received great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. The conference also received support and active participation from medical and pharmaceutical companies interested in treating various diseases related to the conference and its topics up for discussion. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and others, we, as organizers, appreciate and thank them for the support and sponsors they provided to the conference. Ladies and gentlemen, please pay attention. The first announcement. Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you.
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most important global scientific and medical developments in the field of pediatrics, rare diseases, and endocrine disorders through 48 working papers and scientific research that will be presented by a distinguished group of local and international doctors and researchers for the benefit of all attendees, as well as health services, with the aim of improving the quality of life for people in Saudi Arabia and keeping pace with the goals and plans of the Vision Kingdom 2030. The ancient philosophers say, a successful business will inevitably find someone.
طيب السلام عليكم. Sorry for this technical problem, but we'll resume our lecture by Dr. Najia Atiya. Thank you, Najia, for your patience, and inshallah, I think we'll be fine. Thank you.
Okay, thank you.
I think we reach here already, I think. Okay, we noticed that, I think we discussed this study, and we discussed this study also because we said that non-adherence to growth hormone treatment is a huge number, and we need to know why our patients are not adherence to our management. And this is maybe a non-adherence, it can be a part of non-responsive to growth hormone therapy. So this study done, it is a survey of growth hormone compliance among children and adolescents in New Zealand during 4 months interval. This study actually done on 175 patients, median age was 12.1, and they divided the participant into 3 groups based on the compliance. High compliance if they missing no doses, no missing, or only missing 1 dose per week, and medium if they are missing more than 1 but less than 3, and low if they are missing more than 3 doses. And they found that 66% of children missed more than 1 dose per week of growth hormone. And also they found that there is a significant reduction of the height SDS. Excuse me. Hello? No, the other one. Okay. This is it is a significant reduction in height SDS, and there is also another study to prove to us that a non-adherence to growth hormone therapy can affect actually the response to medication, and this is the second study. And this it was a questionnaire study, just requesting from the GPs of the pediatrician on growth hormone to give them a detailed history about the issued prescription of growth hormone, and also to give them a total dose of growth hormone, like the number of vials or the cartridge of the growth hormones they used over previous 4 years. And they found actually that 39% of cases of participants missing more than 1 injection per week, and 23% missed more than 2 injections per week. And the most important that the height velocity also was significantly reduced in the group with missing doses more than 2 doses per week than non-missing doses. So our patient not adherence to medication, and the studies found that this is non-adherence, it is impact also and affecting the response to growth hormone. So we need to go further and know what are the barriers, why our patients are not adherence to growth hormone therapy. This is a narrative-based approach study done in 11 Italian centers and included 80 young patients and their parents. And actually the study, the aim of the study was to see if the barrier of the growth hormone. Why? To understand the real impact of growth hormone therapy on the patient. And they were able to collect 182 narratives. And they analyzed all of these narratives, and they found that more than 50% of the participants, they viewed the injection is painful, and in pediatric and in adolescent about 1/3 of them. And when we look to the adolescent, more than 50% of adolescents here, they think the most burden of growth hormone that it is daily task. But for the children, only 25%, and we understand this because in children, usually the parents are the one running after the children to take the growth hormone. So injection medication and daily tasks seem to be the main barrier to be adherence or to take the growth hormone therapy. This is another study also to assess the barrier, and it is done actually to know the effect of the growth hormone treatment and psychological well-being in the children with growth hormone deficiency. And they found actually that 28% of children, they express their fear of injection, and about 50% of parents agreed on this, and also for adolescent or pediatrician, 1/3 or more than 1/3 dislike treatment by injection. Another study, and actually another one, please. The next. This study, I mentioned it here. I tried to discuss it with you here in the barriers and not in the compliance. For one reason, you are going to discover it now, because this was a questionnaire survey done on good number of adolescents, 326, and in pediatric, about 400 parents. And they found that they just asked the participant to, they want to assess the frequency of missing growth hormone dose based on the specific reason. So they asked them, all the participants, to answer 9 causes why they are missing the dose. Because they are forgetting to take it, or they forget to order medication, they forget to renew the prescription, they were outside home, they are have social event, or just they want to take a vacation from the injection, or they didn't have money to buy. Then they divided the participant into 3 groups. So the compliant, if they answer never for 8 or 9 causes, and occasionally non-compliant if answer never for 6 or 7 causes, and non-compliant if never for 5 or less. And you can discover that for adolescent and children, occasionally compliant the same number, 41, 42, 44, the same for adolescent and the pediatric case. But here's the surprise. You found non-compliance. Who's have non-compliance? Non-compliance, 1/3, more than 1/3 of adolescents are non-compliant to growth hormone therapy, 33%, while the pediatrician or pediatric cases, 1/4. So seem to be being adolescent is a barrier, and we should patient on the adolescent and growth hormone, we have the adolescent, we have to require the special attention, the adolescent age. It is important. So this is the barriers, and now by knowing the barrier, we have to move forward and know the reference of patient, what they want. Next one, please. So this is also about the method of measuring adherence to growth hormone. Do you have measurement? Yes, we can. We can issue, for example, just to count the issued and the renewed or growth hormone prescriptions. This is relatively easy and objective, and provide but only gross measure of adherence. And there is also, we can do a questionnaire like most of the study I mentioned it today. It is simple, inexpensive, but more sensitive to non-adherence and the time dependence for the patient recoil. What about serum IGF-1? Okay, we are using it to adjust the dose of growth hormone, but again, it is not validated to measure the adherence to growth hormone therapy. And what about the machine? We can use, next please. The injected device with electronic monitoring system, yes, we can use it. It can monitor the time, the dose, and it transmitted the information to the physician. So now we are moving to the, know the preference of patient for growth hormone therapy. Next. So this is a quantitatively evaluated study, just try to evaluate the factors driving references for growth hormone regimen, and they use a DCE approach, and it was really a good study because it done on 224 participants, 75 adults and 79 adolescents and 70 children, and you can see here more than 2/3 of all subjects, including the adults, they prefer to have less frequent injection once a weekly or once every 2 weeks or once a month. So most of the patients, they like less frequent injection of growth hormone. Another study, this study, the same study, there is a 0% of adolescent or pediatric prefer daily injection if there is other option of the less frequent injection of growth hormone. Next study here, also Japanese study, and it was more or less the same like previous study, try to assess the preference of the children or the parents for the growth hormone regimen. And again, they found that about 50% of cases of participants, they want less frequent injection, and seem to be they are not caring much about the other criteria of growth hormone, like storage, preparation, dose setting, injection device, or maintenance. They care much about the frequency of the injection. So the daily injection and the daily task, it will decrease the adherence from what we mentioned, and this is increase the demand for long-acting growth hormone. And as you know, we are a pediatrician, and we like to have, we like to know the efficacy and the safety of long-acting growth hormone before using it. Next, please. This is a systemic review of 7 RCTs, and they found that just they are comparing daily with weekly, and it was also in a good number on daily growth hormone 330, long-acting 430, and they found that the height SDS the same, comparable in both group, and also height velocity was same, IGF-1 same, and the side effects also was the same in both groups. So there is the efficacy and safety of daily growth hormone with the long-acting growth hormone of different formulation were the same. So what about who can assure us that if we use long-acting growth hormone, the adherence will be good? If we didn't have data or enough data for long-acting growth hormone to answer this. But we have data from other chronic disease like osteoporosis. They are using daily and weekly treatment. And this is 7 publication. And they found that with weekly treatment for osteoporosis, much better adherence to medication. And also we have data from the real world studies of GLP drugs. Weekly, much better adherence than daily. And this is a last study. Here, this is a really very important study because just published a few months ago, and it is also a systemic review and meta-analysis of 14 RCTs and 2 cohorts. And these 16 studies compare the long-acting growth hormone with daily growth hormone efficacy and safety, and 8 of this study, they also evaluate the adherence to medication, and 2 study about the quality of life. And no study comment about the cost effectiveness, and they found that the efficacy and safety the same, and the quality was comparable with long-acting and the daily growth hormone, but for adherence, the adherence with long-acting was reaching more than 92%, but in comparable study was the same. So the author concludes that for the adherence and the quality of life should be addressed from the real world data study for both mid and long term and in the longer population. So in summary, growth hormone should be available for all children with growth hormone deficiency, despite its effectiveness, but we have a high percentage of patients not responding to growth hormone. And it seems to be that the daily injection and the injection medication and daily task are the barrier, the most common barrier for adherence to growth hormone. And I think we also for long-acting or daily, they have the same efficacy and safety. And we need actually further research to enhance our patient response to medication and also to study the challenging we are facing in the treatment of children with growth hormone deficiency. Thank you.
Thank you, Dr. Najia, for this important introduction on growth hormone. The next speaker is Professor Amir Babakar. Professor Amir Babakar is trained in Cambridge University Hospital in United Kingdom, and he was associate professor, and 2 months ago he became a full professor. So congratulations, Prof. Amir, for this, and he deserved it. He had many researches in the field of pediatric endocrinology and diabetes. He is one of the best teachers I've seen actually in among the trainees. So thank you for being with us, Professor Amir. Also, Professor Amir Babakar is a consultant pediatric endocrinologist in the King Abdullah Specialized Hospital in National Garden, Riyadh, and also he is a full professor in pediatrics. Professor Amir will talk to us about optimizing growth, a comparative analysis of long-acting growth hormone versus daily growth hormone. Professor Amir.
Can I take that? Thank you very much, Dr. Abdulaziz. بعض ما عندكم. We always learn from you and all the senior pediatric endocrinologists in this country. I always tell my colleagues actually that I learned a lot here actually, much more than what I learned in the UK. There's a lot of pathology here and there is a very good environment for learning. So congratulations to all endocrinologists in Saudi Arabia. Okay, so thank you for the organizing committee as well for putting this important topic, which exactly meeting the agenda of the conference, which is update about what's going on and what's new in the field. So I will talk about the phase 2 and phase 3 studies that compares long-acting and daily growth hormone. But before I do that, okay, can you do it, please? Okay, I'll say next to you. So the outlines of my talk will include some history about growth and how people were conscious about this in the past, and also our experience with recombinant growth hormone. Dr. Najia did most of that, so I will skip through the first slides very quickly, and then I will talk about, I will say next to you, okay? So, and optimizing growth, I will highlight the unmet needs, and then I will talk about the different types of long-acting growth hormone in the field, and relatively longitudinal data. We don't have longitudinal data so far, and then the practicalities of treatment and future perspectives. Next. Shall I don't use this one? Here, this one. Okay, sure, thank you. So these are my disclosures for this talk, and also for other supports I received. Okay, very early in history, this is a French journal, published something in the 1770 about the Philbert Montalbard measuring the height of his eldest son frequently from birth to maturity and reporting this. And also people were interested in the summertime and the changes in height measurements during this, and that was one of the first bases of growth velocity and changes of height during to hectic changes or hectic work and changes in the body during the day. This is a very interesting one by Phil, who was measuring his gardener in the beginning of the day and the end of the day, and also he measured his horse at the shoulder before a long journey to Oxford, and he found that there is no difference in his horse height compared to his gardener. So he concluded that this is a shrink that happens in the vertebral column due to muscle spasms. Eventually, the research went forward, and obviously people came to these stages of understanding the control of growth hormone secretion and the regulation of postnatal growth. And the concept of growth velocity is one of the very important concepts in the medications introduced later, and it's one of the markers and endpoints that people judge the success of their medications upon it. So short stage is defined as, you know, the height below the third percentile or 2.5 standard deviations, and there are many causes of this: congenital, idiopathic, and also affected by lifestyles, as I mentioned before, and nutritional, cultural. And there are endocrine causes, the famous known four of growth hormone deficiency: hypothyroidism, glucocorticoid excess, and pseudohypoparathyroidism. And we also have other indications for growth hormone therapy. So there is a very wide experience, more than 40 years now, of success of treating children with short stature with recombinant growth hormone on daily basis, and this dose is adjusted every 6 to 12 months. And obviously one of the reasons for failure of response is not treating the etiology with the appropriate dose, or having a comorbidity in the child, or the non-adherence, which has been clearly highlighted by Dr. Najia in her talk. There is also very wide experience and more than 500,000 patients data that ensures safety of growth hormone treatment, and it is associated with minor problems in their occasion. Actually, obviously, some of them are serious, but they don't happen in a serious consequence during growth hormone treatment. And these are pseudotumor cerebri, slip femoral epiphysis, worsening of scoliosis, and there is no association any proven association that growth hormone is associated with malignancy, although we have precautions in patients who are predisposed to develop cancer. And there are longitudinal studies like SAGI and this KIMS study. So the small for gestational age growth hormone in European children is also KIMS have proven that growth hormone is not associated with development of primary malignancy. We went further more than that, and patients who are cancer survivors, I do endocrine oncology clinic in my institute, and we treat these patients. Obviously, there is a consensus not to treat them with growth hormone until you pass 1 year of the intervention of surgery or chemotherapy. Although there are some special arrangements for some patients who have residual craniopharyngioma, etc., these are treated in special ways. So the unmet needs and why we need long-acting growth hormone, these are the three things in red very clearly. The compliance and adherence, which has been highlighted, Dr. Najia, and the inadequate growth we achieve, and also the treatment burden of having a treatment injections every day. Skip this one, and also this one, which has been highlighted by Dr. Najia, that it reduces linear growth and final adult height. And this has been published and clearly rationalizing the need for long-acting growth hormone as a possible solution for these unmet needs of non-adherence, being a burden, and also not achieving the optimal growth, which is the title of this talk. So the American Association of Clinical Endocrinology clearly stated that weekly long long-acting growth hormone preparations are currently under development. That was in 2019, which may facilitate improvement in adherence. So these are the needs that we look for to be achieved by long-acting. So how can we make the growth hormone long-acting? There are different interventions, chemical interventions to do that, as make it as a depot or a prodrug, or pegylation, which is a polyethylene ethylene glycol modification of and it's called pegylation. This is in one of the types of existing long-acting growth hormone in the market, or it can be fused with proteins or can be attached in a non-covalent bond with albumin, which is an internal protein. So these are the three famous long-acting growth hormones in the market. So we have this one, big-somatropin, and somatrogon, and somapacitan. And the somapacitan is by the mechanism of acylation with non-covalent bond with albumin, and the somatrogon by fusion with protein with HCG, the CTP end, and the pegylation is in this big somatropin type of long-acting growth hormone. And the trade names of them are more famous. Obviously, people know them as Skytrofa, and Sogroya, and Ngenla. So Ngenla by Pfizer, and Sogroya by the Novo, and Skytrofa by the Ascendis Pharma. And the first of them is Skytrofa, that was approved in 2021, and the other two were approved more recently, or more recent than this. So this is the phase 3 of the Skytrofa, and clearly showing a significant p-value of effectiveness and non-inferiority to daily type of growth hormone. We wouldn't go through the details of that. I will go through the details of one of them as an example. So the somapacitan also showing no inferiority of the weekly growth hormone compared to daily growth hormone. And obviously there are recommended doses in each of these phase 3 studies. And the same for the somatrogon. There is non-inferiority with a dose of 0.66 milligram. And compared to the standard 0.34 daily growth hormone dose. If we look at the phase 2 or phase 3 of somatrogon as an example, not in any preference of this medication on the others, because most of the other phases have similar design actually, but this one, the first one is showing dose finding study, the phase 2-1. As you can see here, so it compared 3 types of doses, and the last one is a 0.66, which was found to be more similar to the daily growth hormone. And then we have an open label extension, including 5 years, which is the longest of safety data we have now in long-acting growth hormone. And the year 5 was using the real pen, not just an experimental device. And then we have phase 3, which is a longitudinal comparison and long-acting and daily growth hormone. So this is the phase 2-1, which was in 14 clinical sites. And obviously the primary endpoint was the height velocity by 12 months. And the secondary points is to check that at 6 months, and also to look at the SDS height changes at 12 months and 6 months, and also to look at the safety measures of IGF-1 standard deviation scores. And the key inclusion criteria, including patients from 3 to 10 in girls and 3 to 11 in boys, and those who have growth hormone deficiency, which is the only indication now for long-acting growth hormone, and obviously patients with no chromosomal abnormalities, and those who have a requirement, obviously, by a reduced annualized height velocity and a safe level of IGF-1. And as you can see, in the first standard one, which is the phase 2-1, the most near to the daily one in green, the first column of bars, The green one is the daily growth hormone. So the next to it is a 0.66, which is achieving more or less similar growth velocity. And this 0.66 milligram has been extended in an open label extension to continue longitudinal data to prove safety of using these medications. And we have this used now for 5 years. The second to this is the somapacitan, which is entering year 4 now of using it, and both of them are showing adequate data of safety. So there were some concerns in using somatrogon because there was a high percentage of anti-drug antibodies, and that made the ADA skeptical about approving it first, although it's approved straight away by the Europeans. But obviously these anti-drug ADA positive patients have been compared to ADA negative patients in all phases, and they did not show any inferiority in the highest velocity achievement, and none of the patients have shown any significant side effects. So the conclusion of phase 2 study of somatrogon is that a dose of 0.66 milligram per kg per week is a recommended dose, and it's comparable to the daily one, and it's has got a safety profile, and the ADA, which is the antibodies, are not showing any inferiority or risk or putting on any risk on the patients. And overall, there is 5 years demonstrated safety data and successful sustainable growth over this period. So this is a larger study, 84 clinical sites. This is a phase 3 head-to-head comparison, and it has the same inclusion and exclusion criteria and primary and secondary endpoints, and obviously including up to 500 patients which have been randomized into 2 arms and showing no inferiority of the long-acting somatrogon compared to the genotropin. In fact, if you see to actual figures, they achieved more or better height velocity, but that was not statistically significantly different from the daily one. And there are some variations when you look at the subgroups. So you see that the older age groups above 7 years respond better, girls respond better as well, and those who have severe deficiency respond better to somatrogon. So there was no serious treatment emergent adverse events, and most of the problems that happened with the somatrogon is possibly related to the molecular weight, because it's produced by fusion to protein, so it has the heaviest molecular weight, as you observed earlier, compared to somapacitan, which has 23 kilodalton, and this one is about 47. That's why it causes some injection site tenderness. There is no issues about glucose and A1C as one may expect, and I already talked about immunogenicity. So IGF-1, just a word about that, you need to know the best time to measure it. It has to be measured 4 days after the injection, because this is the time when you have a trough. So if you have it in the first 3 days, this may give you a false impression that the IGF-1 is supraphysiological, but the right time is 4 days after that. So it's non-inferior and achieve a success of about 95% success in achieving the target, and with no moderate to mild side effects, and it's generally well tolerated. And more important than that, we have 5 years safety data on this product so far. So in general, the long-acting growth hormone achieving better adherence and more flexibility. So as you expect, better quality of life. And more than this, in terms of practicality, if you miss the dose, you can give it 3 days later. So this also takes us to something practical, because this can happen. And we clearly meet or addresses the unmet needs by this, reducing the burden on patients, possibly improving the adherence, although we need some studies on this, and this will achieve a better growth target. So we remained with very few slides, which are just telling who to go through the transition. So far, the indication is for growth hormone deficient children, but I'm sure it will come into practice when people have free hand in using it. Then people will try to use it in the non-adherent patient. But we have to bear in mind these risks of possibility of active malignancy, or a genetic risk of malignancy or insulin resistance. This is how to move from a daily to long-acting, so you can move straight away from the day you stop the recombinant one daily to the next day, long-acting. And if you miss that chance, you can do it 3 days later. Remember that the IGF-1 has to be measured 4 days after the start of the long-acting. Whether you can start it in a naive patients or not, real-world data will tell us. This is my almost last slide. We have to remember that you have to choose the right patient for it. You have to make sure that you are doing this in a safe way. It's indicated. Educate the patients well about the use of it, and also educate your staff about how to monitor the progress and the success of your treatment, as well as the safety in terms of IGF-1. This will take me to the summary slide. Sorry, the summary slide, yes, which is we have a wide longitudinal history with growth hormone, safety of growth hormone daily. We have unmet needs with the daily one, and this is possibly closed. The long-acting is closing the loop, and we have realistic option for non-adherent user, but we need some more safety data in the long course. Thank you very much.
Thank you very much, Professor Amir Bikr, for this important presentation, and we'll keep the probably discussion and question till the last presentation, which we'll have it now on the Zoom. The next speaker, are we ready? So we can go on the Zoom. The next speaker is Dr. Walid Goblan. Dr. Walid Goblan is a consultant pediatric endocrinologist, and he is a professor of pediatrics in United Arab Emirates University in Dubai. He's also the chairman of pediatrics at the Tawam Hospital in Al Ain in United Arab Emirates. Dr. Walid Goblan will talk about local experience of using long-acting growth hormone case studies. Dr. Goblan, the floor is yours. تفضل.
Assalamu alaikum. Can you hear me? Can you hear me? Assalamu alaikum. Can you hear me now? Assalamu alaikum. Assalamu alaikum. Assalamu alaikum.
وليد ممكن ترفع صوتك أكثر، يمكن يكون الصوت ما هو واضح عندنا هنا.
Can you hear? Assalamu alaikum.
دكتور وليد، you are okay. عليكم السلام ورحمة الله وبركاته. تفضل دكتور. بالموبايل هي كان جو خلاص.
السلام عليكم.
عليكم السلام. احنا نسمعك يا دكتور وليد، اذا كان تسمعنا انت. Can you hear us?
Can you hear me? Assalamu alaikum. Can you hear me? Can you hear me?
أنا أسمعك.
طيب. Can everybody hear me?
دكتور أنت معنا الآن على اللايف.
Okay, so I can go ahead and start.
Yes, you can start.
Okay. Assalamu alaikum. I apologize for this technical glitch. I would like to thank Pfizer and my friend and colleague Abdulaziz for the kind invitation. And please accept my sincere apology for not being able to be with you for medical reason. I was asked to talk about the long-acting growth hormone and growth hormone deficiency Tawam Hospital experience. So as an introduction, am I going to proceed the slide or you will do it? Next slide. And move to
next slide. You can move the slides, Dr. Benandak.
Well, it's not working, unfortunately. I don't know why. I'm sharing my presentation, but I cannot move in any direction.
Okay. Do it from our side, Walid. Okay.
Okay.
Out from the shared.
All right. Should I try again or? Okay. So as you all know, the long-acting growth hormone Ngenla or somatrogon was approved by the EMA in the beginning of 2023. And about 6 months later, it got the FDA approval. It is approved for the age of 3 years and older with a diagnosis of growth hormone deficiency. The medicine became available in UAE in May 2023, but it was in the private sector initially. About a few months later, it became available in the government hospital, including Saha hospitals in the Emirate of Abu Dhabi. Next, please. Next. Okay, so the main differences between main differences between somatrogon and somatropin, you probably know most of them. So somatrogon is not considered in the UAE as a semi-controlled medication, unlike the somatropin. It is only indicated for growth hormone deficiency, as I have stated, while somatropin can be given for all FDA-approved indications in UAE. Because it is not semi-controlled, one prescription can be given to cover 90 days, while in somatropin, patient has to come to the clinic or to the pharmacy on a monthly basis to get refill, even if the doctor prescribed 90 days in one time. And because of the high cost, somatrogon after 6 months has only been used for Emirati patients because they don't have to pay any co-payment, while non-Emirati have to pay a percentage between 30% or more as co-payment. And somatrogon is a little bit relatively more expensive, so many of my, or actually all my non-Emirati patients elected to stay on the somatropin to basically save the co-payment, which was different between two medications. Next. So our typical candidate to start patient on somatrogon has been patient at the age of 3 and older with the approved diagnosis of growth hormone deficiency. We do use the same definition of growth hormone deficiency that Pfizer used in phase 2 and phase 3 study. That's a peak growth hormone level of less than 10 nanogram per ml following the use of 2 stimulants. That's not necessarily the same clinical diagnosis we have, but again, for the sake of adherence to the approval, basically that's what we use. So all our patients with a level of less than 10 ng per ml have been listed as growth hormone deficient and started on somatrogon if they're the proper candidate. We want to ensure that insurance coverage is provided or patient is willing to pay the proportion of payment after they know the cost of the medicine. And we want to make sure that there is no contraindication. And the two main contraindications that we follow nowadays is an acute major illness or acute case of malignancy. Of course, if there is a known history to somatrogon, we will not use it. But again, somatrogon is relatively new, so we don't have any information on previous history. But should this be the scenario, we will not use the treatment. Next. So when I prepared the presentation about 3 weeks ago, we had a total of 25 candidates. Out of those, we had 2 patients or 2 families who refused to switch to the treatment after they knew that we had it only for a few months. They wanted us to have at least 1 year of experience with the other patients before they switched. So out of being more precautious, so they decided to continue the daily treatment. We had another 2 patients who started, but they had to stop the treatment, and I will talk about them later. This leaves us with a total of 21 patients who are actively on somatrogon. Out of those, we have 8 patients who have been followed for more than 3 months. The male to female proportion is 3:1. The mean current age of the patient is 12 plus minus 2 years. Again, that's not the starting age. Remember, many of those patients have been on growth hormone daily treatment earlier, but the current age is 12. And the proportion of patients who are started newly on the treatment or switch from daily is about 50%. Next, please. So when I calculated the starting dose, the mean dose was 59 microgram per kilo per week for the whole group. And when I looked at the most recent prescription for all patients, the final dose have declined slightly to 54 microgram per kilo per week. The baseline height Z-score is minus 1.9, and the latest height Z-score for the 8 patients who had been followed for more than 3 months is minus 1.7. We don't have the data for the other patients yet, as we need more period of observation. Next, please. So this is only a visual clarification of the baseline IGF-1 and the most recent IGF-1. As you can see, we have some patients who have level increasing. We have some other patients who have the level being about the same. Once again, I want you to remember, most of the patients with the same level are patients who have been on daily somatropine. We were happy with the IGF-1. We just want to maintain the same level, and most of those curve represent those patients, while patients with the increasing curve represent the patients who were started recently on it as a de novo. Next, please. There are 4 things in TAWAM related to IGF-1 level. Probably most of you have the same thing. We have an age-matched reference range, and we have a gender-matched reference range. Additionally, we have a Tanner stage-matched reference range. And if they happen to change the assay, of course, we will have new reference range for the new assay. So we have to keep all those in mind when we look at the IGF-1 level for those adjustment purposes. Next, please. So showing you example here, 1 patient with 4 results. 1 result is reported as normal because it's in black. 3 results are reported as abnormal because they're in red. The reason why they basically listed them as an abnormal because the age-matched reference range for this patient is 15 to 64. So this is the only result. Next, please. When we look at the Tanner stage reference range match for this same patient, who is the Tanner stage 4, the reference range goes up to 112, which makes this one is normal, this one is borderline high, and this one is slightly high. So we usually look at the Tanner stage reference range with more credibility than the age-matched reference range. I just want you to know this basically because I'm not sure what you practice in your centers. Next, please. So collectively speaking, the feedback of the treatment by most of the families that they feel that weekly injection is much more convenient than daily injection, and I think there is no surprise in this. The device itself is very easy to use. It's disposable. The numbers are very visible. The injection is very easy, so they have no problem about using the device. All of them would like to continue using it, except the 2 cases that we decided to stop. Again, I'll explain about them later on. And the medicine has been very well tolerated. There were no new symptoms in patients switched from the daily to the weekly, except for 2 or 3 patients have complained of mild discomfort because they inject 0.5 ml in one injection, and the volume is a little bit more than what they used to inject on the daily. So they have some mild discomfort, but again, they don't mind to continue using the medicine, the weekly medicine in spite of that. Next, please. So the treatment was discontinued on 2 patients. One patient developed acute pneumonia, was admitted to the hospital, ended up transferred to the ICU for 5 days, and then back to the floor for 2 days before we discharged him home. This was reported to Pfizer Safety Network. And collectively, we decided not to continue the treatment. The family didn't feel very comfortable, and they asked for our recommendations. I discussed the case with Pfizer, and we decided not to continue until we have more information. And as of maybe 2 months ago, this was the only case reported when I followed back with Dr. Sisi to see if there are any more cases. I have not heard of any other cases, but I will wait to hear more information officially and formally from Pfizer. Another patient had new onset type 1 diabetes in less than 1 month. However, that patient had 2 positive O2 antibodies. I did explain to the family that the fact there were 2 positive antibodies let us know that this is not related to the treatment, and I encouraged them to switch back, but the family decided not. Next, please. So let's review 3 case scenarios about 3 different things that might happen. I'm sure you're going to have more stories about your patients that we will learn over the time we're using the treatment. Next slide, please. So first one, we're going to talk about unexpected drop in IGF-1. Next. This is 12 years old with growth hormone deficiency as confirmed by growth hormone stimulation test. The baseline IGF-1 was 24, which was well within the age-matched reference range. Patient was started on the maximum dose, 66 mics per kilo per week, equivalent to 20 milligram per week. The mother was asked to do an IGF-1 following the second dose. This is my only personal practice. I do not do IGF-1 4 days after the first dose. I tell them to do it. I tell them to do it after the second or the third dose, just to ensure that we are really in a steady state. So the mother did the test, and after the second dose, 4 days later, the level came back even lower. Of course, I had to question the compliance. Next, I asked the mother if she's missing any dose, and she confirmed that she has not missed any dose. Next, please. And next one more time. So, no, go back. Go back, please. Okay. So here I decided to have the mother come back to the clinic, revise the prescription. I wanted to increase the dose from 20 to 23, which will be equivalent to more than 75 mics per kilo per week. But again, that's the instruction. You follow IGF-1, you make adjustment up or down by 15%. However, I asked the mother what's happening exactly. And the funny thing, when she started to explain to me, she said that the marker of the medicine in the pen, this rubber at the bottom of the cartridge, has not been moving up when she gives the injection, and it stayed in place for after giving 3 or 4 injections. So at that time, we assumed that there was a device malfunction. So again, I called Pfizer to report this, and I told the mother to come and replace the device. However, when she came, I asked her to show me what she was doing. And the funny thing is she was dialing the dose. She was doing the needle injection, but she was not pushing the plunger on the pin. So somehow the mother felt that by dialing the dose and sticking the needle in the subcutaneous tissue, the pen will self-inject the medicine. And again, it was a simple mistake I have not thought of. Of course, when we explain to them, we do tell them how to push, but the mother forgot. So we explained to her that is the mistake behind actually that the marker or the medicine was not reducing. So we told the mother how to give it. We asked her to display to us how to do it. And then 2 days later, next slide. And one more click. I told the mother to use the pen properly, and then 2 doses later, we did the IGF-1 level, and it increased back to 39 nanomole per liter. So the message here, again, be as detailed as you can in explaining to the family, especially the newly diagnosed patient, about how to use the pen. Probably ask them to display in front of you how to use it to make sure that they comprehend all the details. Next slide, please. Second case is about late dose adjustment. This is Yusuf, 13 years old, who had growth hormone deficiency since 2021, was on the daily treatment, and I switched him to the long-acting treatment, somatrozone, on July 2023. The starting dose was 61 mics per kilo per week. Again, IGF-1 after the second dose. Next. And one more click. One more click, please. Okay. No, go back. Go back more. Okay, leave it here. That's okay. So these were the levels when the patient was on the daily growth hormone treatment. Again, don't worry that they're listed in red. They're all normal for the Tanner stage matching range, which is up to 99 and then 112 for my patient. Here, when I switch my patient from daily to weekly, level increased from 81 to 115, and that was high level. This was in 5 of August. 3 months later, the level was still high. So what happened here? Why the level has not corrected? Well, patient missed their appointment with us, and they managed to go to the general pediatricians to refill the same dose, the same injection for another 3 months. So the patient kept using the same dose until he came and saw us in November. When we saw the level in November, we reduced the dose. We reduced it gradually until we reached the dose of 44. So from 161, I can't remember what dose I have went down to. Probably it was 15%. I was not very happy with the drop from 116 to 101, so I wanted it to go down further. So I reduced it until I reached the dose of 44, and the next level was 83, which is again normal within the normal range. Message from this case: patient who will be started on somatrozone have to come back and see you, not to see general pediatricians, because they will not be familiar with interpreting the IGF-1 results and make those adjustments accordingly. Next, please. So this is the interesting case to show that this 4 days post-injection IGF-1 might not necessarily work for everybody. So Muhammad is 13.5-year-old with growth hormone deficiency. Again, he was on growth hormone treatment, the daily regimen, for 8 years before I switched him in May to the weekly. Next. One more time. And one more time. Thank you. So again, patient was switched from the daily to the weekly. And as you can see, when we did the IGF-1, there was a significant drop. Now, luckily, I did not see the result on this day. And patient had to go to ER after 2 days for something else. In the ER, they did electrolyte, and there was a future order for IGF-1. So they repeated IGF-1 only after 2 days, and you can see the remarkable increase. So I saw the result here, and I spoke to the father. I said, usually I would have increased the dose if I saw the result here, but because the level increased, I'm not going to increase the dose. Let's continue the same dose, which was maximum anyway. Let's repeat the level after 1 month on the same dose. And here again, the level after 1 month, now it is 116. So 4 days post-injection is quite different from 1 month after the injection. I have not changed the dose at all. So I reduced the dose. Click next, please. Okay, I reduced the dose to 61. Again, I was not happy with the drop to 111. I wanted it to go down, further down, reduce it to 49, and the most recent one was 106. So again, you need to be careful, and I have spoken to Pfizer, even to Novo, according to about their medication, because they have the same rule. I think it's quite early to consider this 4 days IGF-1 level as a solid drug, correct? And I don't know which patient you need to question that. Again, I was lucky that this patient had been to have a second IGF-1 after 3 days. Otherwise, I would have increased the dose here, and this would have become probably remarkably higher. Next, please. So in summary, somatrozone is the first FDA and EMA approved long-acting growth hormone. It is definitely a more convenient way of giving growth hormone treatment. There are no unexpected side effects so far until we hear further information about the pneumonia. Patient acceptance has been very well. IGF monitoring and dose adjustment need a little bit more time and data to be basically more reliable. Thank you so much.
Thank you, Dr. Walid, for this updating on the long-acting growth hormone. And we'll open now I'll ask the three speakers to come with me, Professor Amir, Dr. Najia, and we will open the floor for questions and discussion. Okay, any question? Professor Abdullah Al-Harbish, please.
Thank you. Question to all our colleagues who gave us very nice presentations, but more on Professor Amir Babakar. Actually, I have a comment and a small question or quick question. Now, the comment I have is, I gave a talk yesterday on long-acting growth hormone, and excuse my transparency in this very much because I feel very important, and I'm going to be transparent with myself first before I move to this session. The majority of my slides and my presentation was concentrating on a one company product, namely Sugraya. And the reason why is that this product has been used for a few months now in Saudi Arabia. But again, that session was sponsored by that company. And today, I think the product of another company, namely Pfizer, has dominated the slides of Professor Babakar, which is okay. But I don't want people to get a message that we are preferring that or that. I think every product is going to have all the advantages and many advantages, and every product is going to have problems. And it is our skill is to find out about the problems on each one and utilize it the best way towards the patient. So I think we, as I said yesterday, we stand the same distance from everybody. And I'm sure Professor Babakar will agree with me in this. The question, because of the time, the question I have is a technical question, and again, excuse my ignorance, or maybe I don't know this. Now, you know, in some hospitals, or maybe in the future, that the physician will be asked to write the dose of the medication in its chemical form. So I noticed that there are different doses in terms of the exact dose, 0.16 milligram for the Novo product and 0.6 milligram for the Pfizer product. Why the difference? Because we are talking about growth hormone. So why they are different? Maybe the answer is simple, but I don't know.
Yeah. Thank you very much for the comment, actually, which is more important than the question, and I can't agree anymore. I think it's very clear message from Professor Al-Harbish in his caliber as well, and his experience is very important for people not to be taking any biased messages. And as he mentioned, every medicine has got limitations and has got success. We need to find out what suits our patients. Now, what I presented is an example, and what he presented is just an example of the phase 3 and safety and effectiveness. The simple answer to the question is the size of the molecule, of how they make it prolonged, with a prolonged action. So if you add a protein from outside, like in Ngenla, which is a Pfizer product, it has a large molecular weight. That's why it needs a higher, I think, a higher dose, and also it is associated with the side effects, the pain on the side. And the lower molecular weight is usually attached with albumin or internal product, or assessed or done by other methods in the lab. So they usually work with a smaller dose. I think that's the answer. I'm not quite sure whether we're all less experienced in this field, and we speculate sometimes in the answers.
Also, to add to Professor Amir, you know, any new product, there is what you call post-marketing surveillance. And we as a pediatric endocrinologist, and of course, we have to report any thing, you know, which is happening. But I think all the companies taking this as part of their regular follow-up on this. So sometime maybe you want to reduce the dose or increase the dose, or you find any probably effect. So I think this is important. It's a routine. But I think the compliance issue is a problem among our children, and definitely finding a long-acting growth hormone where you can use it once a week, that will reduce the compliance problem and barriers. And I think also another important issue is the size of the needle, which most of our probably nurses and educators and maybe doctors forget about it, that we have to use the smallest available needles to use for those children, i.e. what we have now is 32 gauge at 4 millimeter. And I think that is for all children at many age, with an exception of those who are very obese, that we can use the 4 millimeter size. Any more questions?
Just to add to the answer of the question by Professor Herbish, you know, most of these companies use the same technologies they used in previous medications. So this pegylations has been used before by Ascendis Pharma. And this method of adding the HCG protein by Pfizer has been used in one of the hematology medications, and also Pfizer's Sugroya, this non-covalent binding with the protein has been used with other medications. And big somatropine has got the similar molecular weight to the Sugroya, 22 kilodalton 23. That's why possibly their dose is very similar to each other. But when you use a high protein from outside, you need a high molecular weight. That's why the dose is big.
My question is for Professor Amir. Thank you for the presentation. For the presence of anti-drug antibodies, you mentioned after 1 year it was not clinically significant. My question is, was it studied beyond the 1 year?
Yes, I have shown you a table, one of my tables, shown a data of the open label extension. And during all of this period, there was no inferiority in the height velocity.
Was the patient requiring higher doses of the same medication?
No, not really. There is no difference between the ADA positive and ADA negative in terms of
I'm connected. Are connected? Yes. Okay. Let me.
So there is no difference between the two groups longitudinally over the 5 years period.
Thank you.
I think with this here, because of the time, we will stop now, and then we'll go for the coffee break, and we'll be back here at 3:30 exactly. 3:30. We would like to thank Dr. Walid Kublan, and we will probably provide this, Dr. Walid, to
thank you so much.
Thank you very much for your presentation, and wish you all the best. Thank you.
Thank you. Appreciate that. Thank you.
We are going to have break now for 15 minutes, please, for saving the time. We will start the next session at 3:30 exactly. Thank you.
Ladies and gentlemen, the scientific and organizing committees of the second conference, Updates on Endocrine Disorders and Rare Diseases in Pediatric, are pleased to welcome you.
I would like to welcome you in Jeddah. Welcome all. We are waiting for you.
Please come and join us in this conference and see you then.
I would like to inform you
I would like to welcome you to your conference.
After the success of the first conference in June 2022, the committee began early preparation for this conference, which is organized by the branch of the Saudi Society of Family and Community Medicine in Jeddah, in cooperation with its partner, the Gulf Group for the Study of Diabetes, the Saudi Group of Endocrinologists, and the Experience Forum Company for organizing exhibitions and conferences. This joint work has helped us reach this distinguished stage with your presence today. Our conference will discuss the most scientific and medical field of pediatrics.
Good afternoon, Professor Magni. Do you hear me?
Hi, could you hear me? Could you hear me?
Yes, yes, everything is fine. The setup is okay. Please, Professor, can you share screen just for trial?
Yes.
صباح صباح ايوه
رفع عدنان
ايوه
رفع عدنان المحاضرة حذفتها
انت حذفتها؟ ايوه انا كنت كذا
لا عشان ما هي موجودة عندي
حذفتها لانه في اصفر مرضى انا ما اخذ اذنهم فمشكله يعني
لا
خلاص حذفتها
خلاص
طيب جزاك الله خير
هو ربع ساعة قول له رف محمد
Here we go.
Great, Professor. Everything is fine.
Full screen. Yes. Okay.
Great. Thanks a million, Professor.
That's okay.
We will just inform you when to start.
Okay. Please, could you confirm if you hear me very well?
Yes, we hear you well.
Okay, great.
Thanks a million, Professor. We are supposed to start after 15 minutes exactly, but we will tell you for the countdown.
Okay, that's going to be at 1:30, right?
Yes.
Okay.
Can you just move to the next slides to make sure it's fine?
Yeah, of course. Fine.
Great, great. Everything is fine.
Everything is fine. Okay.
Great. Thanks a million, Doctor.
Great.
This joint help the most important global scientific and scientific research that presented by a group of of all attendees, as well as health services, with the aim of improving the
دكتور محتاج دكتور ايوه عشان دكتور سافاج ما دخل الى الان
ما في سافاج لسه ما دخل هي بينه وبينك في كوميونيكيشن
عشان ندرب لا يحصل اي فرق
انتوا جبتوا الاثنين دحين
دربنا مع الدكتور
ففي
محمد مغني
لا
اوكي
باقي ففل
دحين حنجرب
ففل جرب وانا اقول لك دحين
طيب
سويت له افتر انميوت ما
بروف رونالد
Roland, can you hear us, please? If you can unmute your mic. Prof. Roland. Prof. Roland, can you hear us?
قلت لك الحل تجيب ممكن تجيب لك 15,000 خالد اقسم بالله الحد اي واحد 15. خمسة اليوم يوم 5 هيك جدول على اساس مو زي 17 لا والله اليوم 5 يوم 17 ليش عندك؟ ما عندي شغلة كذا لازم على بالي خلص أربعة شيء عادي على 4 كذا سبت لي كادر وايد أشياء مهمة خلصوا والفهم بس تدخل كذا نزلون علمني شلون أقفل الجرين من هذيك السلام عليكم الله يحفظك يا دكتور الله يحفظك في أمان الله توصل بالسلامة إن شاء الله أي نعم هذيك بقفلها مو هذيك استنى عم بحكي ما حد يحكي صار كل اختراع ما بجيب ودخلهم شوي شوي كل فترة حتى كلمت واحد والله أمس دق علي قال لي هو عنده امرأة فكأنه يبغى يجدد من شركة كبيرة قال عندنا دورتين بدنا كانت قلت له شوف أنت إيش لا بس أكلم شريكي استخدم كل شيء أكلم شريكي جميل يعني حتكون يعني على ميز 500 صراحة السوق 400 الحين هو كانت عندي 350 لا 350 جبت 240 ضفت عليه 400 عشان لا بس حتى 500 حتى الاثنين حتى ال 400 ببيعهم احطهم كله ماشي وصرت تمشي على هذا كم اسعار ال 400 شيء دور على الأخبار مش لاقي حتى لو 500 ايوه على اليوتيوب كيف طيب اسمه لو تكتبي هذا العنوان وهذا اسم القناة صوريها بالجوال عشان تدوري طبعا هذا لحاله يعني ايه هذا بجيب لا بجيب ايش؟ بجيب افعال بجيب ايش؟ عايز احسن وحدة صوت ان شاء الله عشان توصل للانزلاق خلص جميل شيء شغلك بالدولة انا ما تغديت روح في كافي بريك روح جيب لي من هنيك دفشة هي التمر اللي هيك جبت لي اياها قلت لي ما في شيء اعطي لي اي زفت اكل اعمل لي عصير اذا في عصير ما رد Bro Roland, can you hear us, please?
Yes, I can hear you.
لا Bro Roland, sorry, not Dr. Muhammad.
Okay.
Sorry.
say, a successful business will inevitably find someone to see great support and assistance from various health sectors in the Ministry of Health, Jeddah Second Health Cluster, and some other government sectors. Khan also received support and interested in treating various diseases. In addition to their interests in awareness and health education for patients, endocrinology, childhood diabetes, and other, appreciate and thank them for the support and sponsors they provided to the conference. Ladies,
السلام عليكم ورحمة الله وبركاته، ومرحبا بكم مرة ثانية مع الجلسة العلمية الأخيرة لهذا اليوم. الصماء والأمراض He is a fellow of American Academy of Pediatrics and fellow of Royal College of Pediatrics in Canada. Dr. Al-Herbish is well-known professor and consultant pediatric endocrinologist. He has more than 98 publications, that is in very short. I introduce also Dr. Khairiya Musa. Dr. Musa is senior consultant of pediatric endocrinology and genetics, clinical leader in the group. She is the founding member of Saudi Health in Jeddah. You can start.
Thank you very much for this nice introduction. You to be given by very distinguished speakers internationally. First of all, I would like to add to what has been said in the introduction for my colleague, Dr. Khairiya Musa. She is well known to all of you as a very active and a distinguished pediatric endocrinologist in the area. In addition, I think many of you know her contributions to the not only to the medical field but also to the community level. She has great to give this introduction before we start, but she will be introducing the first speaker to you.
Thank you, Prof. Harbish. Assalamu alaikum wa rahmatullahi wa barakatuh. I have the pleasure to introduce our next speaker, Prof. Mohammed Maghani, who is a professor of pediatric and director of pediatric residency program, University of Geneva, vice president, director of Department of Neuroscience, maternal clinical service in pediatric endocrinology, diabetics, metabolism. Dr. Maghni will give us an update on the care of achondroplasia, how to improve the treatment strategies. Dr. Mohammed, the floor is you. Faddal.
Assalamu alaikum. This is Mohammed Maghni. I'm pediatric endocrinologist based on Geneva. And would like to thank the organizers and BioMarine for inviting me to this meeting. It's a great pleasure. So these are my disclosures, some important notes. And what I would like to share with you over the next time available and outline is what are the main key complications throughout the life course in subjects with achondroplasia. Then give you some information about real-world data, some European data from the LIAISE study and the clarity, and then move to the growth, the importance of growth and specific measurement, and then give you some insights about the treatment strategies and some personal experience. And finally, go to the summary. So achondroplasia is the most frequent skeletal dysplasia associated with disproportionate short stature. And its incidence is estimated around 1 case to 125,000 live births with no differences based on sex or race. And 80% of individuals have de novo spontaneous genetic change, and it is autosomal dominant transmission in 20% of the cases. And almost 90% have the same single point mutation. And these mutations arise from 2 possible base substitutions, leading to a gain of function of the FGFR3 receptor, and consequently resulting in impaired endochondral ossification. So here you can see that the FGFR3 is transmembrane receptor in the FGFR3 factor signaling pathway, and it is negative regulator of growth plate activity. So the disorder will result in failure of normal cartilage conversion into bone, and consequently the complications arise secondary to bone compression of neurologic tissues and other bone-related tissues. And this will lead to the disproportionate short stature due to the rhizomelic shortening of the lower limb. And here you can see that the upper segment in subject with achondroplasia is overlapping that of the normal population. So here you can see the normal population is indicated by the dashed line as compared to the solid line in patients with achondroplasia. And this is completely different in the lower segment, where achondroplasia population is below normal as compared to the controls. And it's important to raise the issue about that people with achondroplasia have normal intellect. This is in the absence of neurological compromise due to cervicomedullary compressions or hydrocephalus or other complications. So here you can see some multi-system comorbidities in achondroplasia affecting the craniocervical conjunction. And here you can see, and this starts early in life, up to 3-5 years. And ear and nose could be involved with recurrent otitis, hearing loss at any ages. And of course, orthopedic issues that includes the shortening of the upper and lower extremities, some genovarrior, spinal, some discoid meniscus and elbow contractures. And then at the level of the spine, this is common, approximately between 10 to 20% of cases might have orthopedic burden. And then cardiopulmonary complications, including sleep disorders and metabolic issues like obesity. So in this cartoon, you can see that comorbidities are represented with a burden across a broad range of age. So here are some examples about the complications associated with achondroplasia. And you can see this foramen magnum stenosis, and these are scores that we have published in more than 5 years ago. And now there are some recommendations from the neuroradiologists in children living with achondroplasia. There is a consensus published in November 2023, and it is extremely important to share these information. So here you can see this is scored from 0 to 5 at the level of foramen magnum stenosis, at the level of spinal stenosis. And here you can see some example about genovirus, some signal alteration of the MRI for the meniscus. And here you can see some alteration about the spine. So let me summarize what are the risks associated with achondroplasia. And here you can see 100% rhizomelic shortening of upper and lower extremities, and this leading to improved functionality, 100% delayed motor skill acquisition, 6 times more increased risk of sudden deaths due to foramen magnum stenosis and cervicomedullary compression. 70% of the patients experience chronic back pain by age 50, and 50% experience chronic leg pain by adulthood. 10 times higher expected number of deaths from heart disease ages between 25 to 35, and 10-year reduction in overall life expectancy, and 2 times higher overall mortality rate compared to the general population. And here you can see this is a recent study by the Italian community about the management of children with achondroplasia, and this is the results of the clinician and parent caregiver survey, and this has been stratified by age, as you can see. And in this slide, you can see that the MDT is mandatory, and that burden across ages have been reported. That include orthopedic surgeon, physiotherapist, ENT specialists, neurosurgeons, etc., etc. Now let me move to the second part of the talk about the real-world data of comorbidities, reporting some results on the LIAISE study and clarity. What is the LIAISE study? This is a lifetime impact of achondroplasia in Europe, and this have involved more than 13 sites in 6 countries, including Austria, Denmark, Germany, Sweden, Spain, and Italy. And 186 overall patients were enrolled. 40 patients had limb lengthening, and this was capped at 20% for the study protocol. And the mean of the study, the mean age at the study enrollment was approximately 22 years. And here you can see some of these results. This has been published on Orphanet Journal Rare Disease in 2023. And you can see this U-shaped bimodal distribution across the study population, occurring more frequently in the youngest and the oldest. And at least one complication or surgery was reported in 95% and 70% of the patients, and this include, of course, ENT, include orthopedic problems, spinal deformities, and all these orthopedic. And the most frequent surgery, as you can see in this slide, varied by age as well, and this is in line with the complications profile. And approximately 80% had at least one achondroplasia-related surgery in one of these categories. So this including spinal corrections, brainstem decompression, and limb lengthening. So now let's move to this clarity study from the United States, and this include more than 1,000 patients, 1,374 patients with achondroplasia from birth to 75 years. And this enrollment include 4 USA centers that are experienced in skeletal dysplasia. And let me share with you some of these data showing in this slide the achondroplasia-related surgical categories, and showing that more than one achondroplasia-related subject was observed in 80% of these patients. And this includes 65% for ear and nose, 20% for foramen magnum stenosis, 12% for spine, and 21% for extremity. And this other paper shows the achondroplasia 60-year experience in decompression of foramen magnum stenosis. And here you can see these have been stratified by age, and you can see that the prevalence of CMD was 20%, with more recently treated patients in the early age. And here you can see this are stratified by years. And in recent years, you can see that the increase in better surveillance, this contributed to earlier identification of foramen magnum stenosis and complication. And this is the Kaplan-Meier curve showing the percentage of patients alive at each age between 80 and 0. And the data demonstrate a rapid increase in the need of CMD over the first several years of life, and this between 0 and 5 years. And improving, of course, the outcomes. And here you can see that these patients who undergone the foramen magnum stenosis are represented by 6 months and 3%, 8% by 1 year, 12% by 18 months, 14% by 2 years, and 16% by 3 years. This thanks to the MRI and to the early referral and early intervention. What about the sleep disorder studies? And here you can see that the polyobstructive sleep apnea was reported in 30%, so among 1/3 of the patients. And age-first polysomnography was approximately at 4 years, and more on polysomnography was reported in 40% of these cases. And here the type of orthopedic surgery, and here you can see that approximately at 9, any orthopedic surgery was observed in 10%, and the spine procedures approximately 17%, 8% of the lower extremities, and 9% of limb lengthening. So this Kaplan-Meier as well showed that the achondroplasia-related surgical categories in primary achondroplasia showed that these patients at 10 years of age in the left-hand side, approximately 90% of these patients undergo the orthopedic surgery, and this is 40% at 20 years of age, and this is 60%, 85% at 60 years of age, and more than 95% at 80 years of age. And in the right-hand side, you can see the Kaplan-Meier curves for patients undergoing laminectomies and spinal fusion by age, and the same at 10 years is approximately 4%, at 20 years of age is 40%, at 40 years it approximately 40%, and 60 years it approximately 69%. So all these studies demonstrated that across lifespan, achondroplasia is associated with multi-system complications, reduced quality of life and functionality, and increased pain, highlighting the large amount of healthcare resources that individuals with achondroplasia require throughout lifespan. Now, some of these guideline principles that we have published in 2021, I would like to share with you is that achondroplasia is a lifelong condition that require lifelong management by experienced MDT. When a diagnosis of achondroplasia is made or suspected, either in utero or after birth, the family should be referred as soon as possible to physician experienced in achondroplasia. The decisions around management should be made by MDT, and the primary goals of management are enable anticipation, identification, and treatment problems. Patients should have access to a variety of adaptive measures, support to ensure proper usage and access to approved treatment options, and regular monitoring, of course, in adolescence, and transition to adulthood should continue under MDT with expertise in achondroplasia. So let's move to the third part of the talk, which is related to the gross and specific measurement. And these results, again, are reported from the natural history of achondroplasia via Clarity study. And in this study, over 37,000 lengths, height, weight, and hazard circumference were reported. And here are some of the curves. These are the curves in males and females with achondroplasia. And these gross curves were developed from cross-sectional and longitudinal patient level height data. And this paper, reported by Hoover Fung in the American Journal of Medical Genetics, provide new height for age, reference curves, and tables of mean and standard deviation for calculating zeta score from birth to 16 years. So, and here you can see there are some gender-specific height percentile curves and these were constructed for 0 to 36 months and from 2 to 16 years. And now let me give you just a flavor about some curves and European curves. And here you can see, just for the sake of clarity and time, you can see in the upper part, this is a sitting height, and you can see that the patient with achondroplasia show some measurement that are above the general population for sitting height. And here you can see these are the scatter plot measurements in males and females. And this second part represent, and I would like to ask you to focus on these two, and these represent the legs and arms in achondroplasia are already at 2 years of age, considerably shorter than a general population. And this deviation increase, of course, for age. And in the right-hand side, you can see this is same for legs that are almost 50% shorter than a general population, and arm span roughly 35% shorter. So these have been reported in by andRare Merker in the American Journal of Medical Genetics. And just like to share with you in this slide, you can see on the left-hand side, this is for boys, and the right-hand side for girls. And you can see that this shows that height velocity of children with achondroplasia, these are males and these are females, the dashed line compared to average, and these are current evidence suggests that the pubertal growth spurt in achondroplasia is absent or really attenuate. So now let's move to the last part of the treatment strategy, and this will include the new treatment and new drugs. And as you know, until recently, there were no approved treatments that address the underlying address the management of growth. Growth hormone has not been approved by FDA and was approved only in Japan, while limb lengthening surgery, you know that is complex, painful, and risky. And of course, it is associated with multiple potential complications. So now we have a new drug. This is kind of precision medicine, and it's called vosoritide. And it is based on naturally occurring CMP, natriuretic peptide engineered to resist the degradation. And CMP downregulated the aberrant FGFR3 signaling pathway in chondrocyte by inhibiting the MAP kinase ERK pathway, leading to improvement in the proliferation and differentiation of chondrocytes with matrix synthesis. So this drug has been approved in 2021 by the FDA and then by the European Medicines Agency, and it is also approved in Japan for children from birth who have achondroplasia with open growth plates. In addition, it has been approved in Brazil in children who are 6 months and older, etc., and now it is approved in Europe as well for patients who are 4 months older, from 4 months to 14 years until epiphyseal cartilage closure. So I'd like to share with you, this is the first study reported in New England Journal of Medicine by Ravi Savaryan, and here you can see this has been a study, dose finding study. And in this slide, you can see this is in the upper part in red. This is the dose used at 2.5 microgram per kilo. Then other dose up to 7.5 microgram, 15 microgram, and 30 microgram. And the result of the study showed that 15 and 30 microgram per kilogram, they have similar results. So the study showed that this profile was generally safe. And here are the results in terms of growth. And here you can see the study baseline observation, and then in the study group was treated with vosoritide as compared to the placebo group, and it showed that there was increase of 1.57 centimeter per year versus placebo, and this is the extension study leading to an increase of 3.34 centimeter in 2 years' time. And in this slide, you can see the mean increase in annual growth velocity of 135 centimeter per year, and this after 5 years of treatment. And this shows maintenance of annualized growth velocity over time. And these are the summary of the vosoritide clinical trial program. Some of these studies have been completed, some are ongoing, and some are planned. And here you can see, and this is a most recent study for children from 0 to 12 months. So in summary, this is a drug was resulted to be safe. There's no difference in the nature and pattern of adverse event of children younger than 2 years or older than 2 years. And no specific adverse event have been reported, unless for some hypersensitivity in some children. What I'd like to share with you, this most recent study reported in the Lancet Child Adolescent in November. And this study showed that, as you can see on the left-hand side, the mean gain in height was consistent across these cohort, and one is between 24 to 59 months, one is between 6 to 23 months, and the other cohort of less than 6 months. And what I would like to share with you, beside the information on growth, is what happens at the level of the face, of the skull, of the sinus, and the area of foramen magnum stenosis. And here you can see that are changes from baseline to week 52 in volume face, in volume sinus, and area of foramen magnum stenosis. And so all these variables show that facial volume increased by 44% versus 34% in the placebo, and the sinus volume by 129%, and foramen magnum stenosis area increased by 44% compared to 25%. So just snapshot about the personal experience in the clinic. And here you can see I have elaborated some statistical analysis among 35 patients treated. And here you can see that the distribution between males and females was not dissimilar. And here you can see what is our practice. So personal and family medical history usually are collected, exclude possible contributing causes of poor growth. The family is informed about the consent, height, sitting height, leg length, and arm span. Cardiac evaluation at first visit before starting therapy. Blood pressure is indicated, and of course, it's difficult in children less than 2 years. And before starting, ensure continuity of dispensing of the drug, and it is necessary to register the batch number. And here is some measurement, and you are familiar with. And so we have a dedicated nurses, and this is theoretical, practical, therapeutic education has been developed. So we have some theoretical explanation shared with the parents, evaluation of the level of the family education with a questionnaire, check for the presence of any impairment in preparing and administering vosoritide, simulation with training sample, practical administration in the clinic by the mother and father in 2 different days. We have contact by phone after 1 week and telemedicine after 1 month. And here's some of these measurements. And here are the results from real world data. And here you can see these are 22 patients before puberty. And you can see the increase from -0.75 to -0.23 zeta score. And here you can see by stratifying into 2 categories, between 5 to 10 years or 10 to 14 years, and you can see the increase either in the height or decrease in BMI. No significant adverse events were reported. And of course, this is a summary in this table of the top line safety summary. And you can see that no adverse events were reported by the investigators among all the studies reported in the literatures. So let's go to the summary. Achondroplasia is a medical condition with lifelong multi-system complications. Addressing age-specific morbidities can be life-changing. Clinical burden and healthcare resource use are high in the youngest and oldest age groups. This has been demonstrated by the Pfizer body and the Clarity study. Follow-up should be based on anticipatory and multidisciplinary approach in order to prevent severe disease, optimize clinical outcomes, and improve quality of life. Key common global challenges remain, such as adequate and equitable access to specialized medical care and processes that allow efficient transitioning of patients from pediatric to adult centers. And finally, insights from this natural history studies are especially critical in the context of emerging precision therapy for achondroplasia. So, benefit, of course, of early treatment. I have shared the data on the Lancet about foramen magnum stenosis and possibly changing at the level of the skull as well. So this was my last statement. I would like to thank you all for the attention and thank all my collaborators, the multidisciplinary team at the Gaslini Hospital. And of course, I would be happy to take questions. And I'm sorry to say that I have to leave, but because I'm committed for another meeting after my talk. So happy to take any question if there are anyone.
Yes. So thank you, Prof. Maghni, for your very nice summarization and experience in treatment of chondroplasia.
Cannot hear you very well.
Anyway, this is a recognition for Professor Maghni for his participation. Thank you, Dr. Khairi. Allow me to proceed because of tight time we have. Professor Savage, can you hear us?
Yeah, I can hear you. Can you hear me?
Yeah, yes, we do. Good afternoon, Professor. How are you? If I can see it or two before I.
Okay, shall I share?
University professor. Professor Martin Savage is well known to all of you. He's professor of pediatric endocrinology at William Harvey Research Institute at Parts at the London School of Medicine and Dentistry, Queen Mary University of London. He is very well known in the field of pediatric endocrinology. He's actually, according to a CV I have in my office, which is at least a year and a half old, he has about 269 publications in international journals. He's the author of about 12 books, and he's a reviewer in many international journals, and he has been invited to many conferences all over the world to be a distinguished speaker. I know that he is a constant speaker in the European Society for Pediatric Endocrinology. We see and enjoy his talk very much. I also admire him for his good leadership. An example of this, which is a small portion really, is his leadership in chairing an advisory committee organized by Merck for many times, at least 7 or 8 times, and this is called ELITE. And the distinguishing part of this meeting was our ability as a group under his leadership to produce actually publications out of whatever discussion we had. Professor Martin Savage, if I continue talking about his CV, I need 1 hour, but I may go straight to introducing the topic he's going to talk about this afternoon, which is embracing innovation, maximizing treatment outcomes for pediatric patients with recombinant growth hormone. Martin, the floor is yours.
Yeah, thank you, Abdullah, but I'm not, I can't see my slides. And can you see my slides? Okay, I can't hear you now.
With your name on? Can you share your slides, Professor?
Yeah, I'm trying to. Can you see my slides now?
Probably not yet. I see one slide with your name on, but it may be from our side.
Yeah. Okay. Okay. There's a problem here. I think I need some technical help from your team, basically.
Yeah, they are helping. I hope they will succeed.
Actually, I can see his slides if you can hear me.
You can?
Yeah, I can see him clearly on my laptop.
Okay, so...
But again, Prof. Martin, I'm also attending remotely with you, so it sounds like the group on site have some issues. Yeah, I can see everything clearly. Abdullah, can't you see it there?
No, not yet. If you have his slides, can you do what you did before, that you control the slides from our end here? And Professor Martin Savage
yeah, that would be good.
To next. If you have the series here, just show us the first slide, and Professor will kindly ask you to move one by one.
Yeah, that would be good.
You do have do they have them? Because if they don't, you can pass it to them. Okay.
Okay.
Professor, yeah.
Okay, shall I start? Can you see my slides now? Okay, I think, can you see my slides? Can you hear me?
Yes, we can hear you.
Okay, do you have my slides on your screen?
Yes, they can also be seen on the screen quite nicely. This is Roland, by the way.
Okay, hi, Roland, yeah. Do they want me to start?
I think they asked you to start off, I think.
Did they?
Yes.
Okay. Okay, I'll start. Right. So you've heard the title of the talk, which essentially embracing innovation, maximizing outcomes for pediatric patients with growth hormone treatment through the holistic ecosystem. Okay, I can move the slides. So this is just my biography, which you've heard about. Thank you for inviting me, by the way. It's a great pleasure to be with you and to participate in this meeting. So here is just an outline of the topics I will cover. And the question is, how does digital innovation contribute to these different areas? Does it contribute, yes or no? And we will be asking this critically throughout the talk. And here you see the growth hormone journey, right from initial identification of short stature, referral, diagnosis, management, and then, of course, adherence and long-term outlook. And I will be covering different aspects. So growth hormone deficiency is diagnosed late in most countries. Actually, Germany and specifically Leipzig, I think you have probably the best results in terms of age of diagnosis, which is very impressive. But most countries and institutions diagnose growth hormone deficiency only when the child is seen to be shorter than his or her peers at different ages, particularly primary school entry and secondary school entry. So there is emphasis on how early can growth hormone deficiency and other growth disorders be diagnosed. And currently the best data comes from Finland, where they have put in place a process of automated height monitoring. Now, there's a tradition in the Scandinavian countries of very careful and repeated measurements, which certainly we have not been able to imitate in the UK. But what they've done in Finland is that they have programmed, using digital innovation, they have programmed a computer to recognize 3 fundamental abnormalities in height. And these are the height, distance of height standard deviation from the average, distance of height standard deviation from the target height or the midparental height, and the change in height standard deviation score over time. And these are the rules which have been programmed into the computer. So what has also happened in Finland is there is enormous investment in the employment of pediatric primary care nurses. And they are all taught how to measure accurately. So the program starts with the primary care nurse measuring the child at different ages in early childhood, and then inputting the height data into the computer. The computer is programmed to recognize one of these 3 abnormalities, which I mentioned. And having recognized that abnormality, there is communication with a secondary care growth consultant who looks at the data and decides if the child should be investigated. The child is then investigated, and basically this leads to an early diagnosis of a number of conditions which are shown here. So you have 2 columns. The middle column is the diagnosis of disorders following the standard referral procedure. In other words, before automated monitoring. But automated monitoring has resulted in the early diagnosis of important conditions such Turner's syndrome, celiac disease, growth hormone deficiency, often in the first 2 or 3 years of life. And this is the only program I'm aware of that has been able to do that. So here, digital innovation definitely has contributed. So then we come on to the assessment of the child with short stature. And, you know, we hear so much about artificial intelligence these days. Artificial intelligence will do this, artificial intelligence will do that. Can it do everything? Well, it's important to recognize now in 2024 that AI cannot do everything. And the contribution of AI needs to be looked at critically. If you look at some of the benefits, AI can, of course, measure bone age. It can help in monitoring growth hormone adherence. It can, in some situations, recognize syndromes through digital facial recognition. But the things that it cannot do are shown on the right. It cannot reason or draw upon experience or intuition. It cannot gauge emotions or instincts or psychological variants in the patient, such as doubt, fear, suspicion, or confidence. And basically, it cannot create the patient-physician relationship or test the strength or weakness of that relationship. So it's very important to remember that. So this slide just shows the general scheme of the investigation of a child with short stature. And of course, we start with the history. Now, the history is typically a clinical skill. Can AI do the same job in terms of taking a history, or even a better job than a human doctor? That's the question. Now, these are some of the, I'm not going through this in detail, these are some of the topics which are included in the regular taking of a history from a child with short stature. And I'm going to show you an example of where AI can succeed or fail. So this is a 14-year-old boy who comes to the pediatric endocrinology clinic complaining of short stature, he's not growing, and delayed puberty. You see on the right that he's, for a 14-year-old, he has quite delayed puberty. And if we used AI, we would simply tick boxes. For example, no respiratory symptoms, you tick the box. No gastrointestinal symptoms, you tick the box. No urinary symptoms, you tick the box. And as a result of that, the diagnosis would probably be made of constitutional delay of growth and puberty. This is the commonest cause of delayed puberty, after all, most likely diagnosis. Well, what happened? So we gave some testosterone to boost pubertal development and growth. And the next time he came back to the consultation, his height velocity had only changed very slightly from 4 to 5 or 6 centimeters per year. A poor response. Why was this a poor response? Because the diagnosis was wrong. As simple as that. What should have happened? Okay, when he came to the clinic, he complains of these different things, but the doctor then asks direct questions, not ticking boxes, but direct questions. Does he have gastrointestinal symptoms? No. Is his appetite good? Yes. Does he have abdominal pain? No. How many times does he have his bowels open per day? 2 to 3 times. And immediately the pediatrician realizes that this could be abnormal. What makes him have his bowels open? Immediately after a large meal, he rushes to the toilet. Again, that is abnormal. These are points this is information gathered through direct questioning, which would not typically occur in an AI program. So basically, he needs further investigations. He has further investigations. He's marginally anemic, and his celiac antibodies are positive. He has a jejunal biopsy for celiac disease, which is positive. It's abnormal. He has celiac disease. Now, that could well have been missed if an AI program had been used. So basically, he then goes on to the correct treatment, and the correct diagnosis has been made as a result of those direct questions. Next, we come to the physical examination. Now, can AI do a better job, a more accurate assessment than the doctor? Okay. Part of the skill of being a clinician is to examine the patient carefully and look for dysmorphic features. Would an AI program pick up subtle abnormalities, as you see in this child? Here, the abnormalities are more obvious, and here they are very obvious. But the question is, could a computer do this better than a human? Because if it cannot, then there's no point using it. So basically, just an example of how I believe clinical skills are still superior in terms of physical examination and recognition of subtle dysmorphic features. Then we go on to screening investigations. Now, on the right, you see a list of screening investigations, general pediatric investigations, which I believe should be done when we see a child with short stature of unknown origin. And these are recommendations which we made in a consensus document published in 2008 in children with short stature. But this has been questioned. And in 2013, Dr. Sisley from Cincinnati essentially described how the investigations which we recommended were done in 235 short children, and the screening tests were not cost-effective in healthy short children because 98.7% did not have any pathology detected on these screening tests. Now, you can just imagine that a company trying to sell AI equipment for use in a clinic will get hold of these data and demonstrate to the health authority of the person who they want to buy the equipment, look how these tests are necessary. So I think that is a danger. Personally, I strongly believe in general pediatric screening tests because you cannot assume that the short child in front of you, if you don't do the tests, you cannot assume that they do not have celiac disease, Crohn's disease, or a subtle form of Turner syndrome mosaicism. Unless you do the test to demonstrate that the child does not have these abnormalities, you are in the dark. And that's why I believe that screening tests are important, but AI could quite easily dismiss them and say, not necessary. But of course, AI can assess bone age, we know that. And then we go on to growth hormone stimulation tests. Now, these remain the cornerstone of the diagnosis of growth hormone deficiency in our patients. Are they needed? Is this test needed, or can it be dispensed with because it's not necessary, or again because it has been criticized for being inaccurate and not reproducible? I think it depends on clinical judgment whether or not you perform this test and how you interpret this test. Personally, I believe in the test. I think it gives helpful information because it distinguishes the children who have definite growth hormone deficiency on the left of the graph from those who definitely do not have growth hormone deficiency. And that is a very, very important distinction when it comes to treatment. I believe also in performing sex steroid priming in children who are investigated around the beginning of puberty, because this eliminates the patient with constitutional delay of growth and puberty who will show a normal growth hormone response after sex steroid priming. Again, there's a trend for sex steroid priming to not be performed in many centers, particularly in the United States. Personally, I think it is helpful. And what about assays such as IGF-1? IGF-1, a notoriously difficult assay, but again, precision medicine has come into the fore and has tightened up the quality control of measurement of IGF-1 and IGF-BP3. And that is a positive influence of precision medicine. What about initiation of growth hormone? Again, I think that the mathematics of these prediction models, first published, of course, by Michael Ranke, I think it's very important. Now, people will say that it's difficult to use these calculations in the clinic. It takes too long, etc., etc. But it's the result of these calculations that have taught us some very, very important rules. For example, in growth hormone deficiency, it is the severity of the growth hormone deficiency which is predicting the best response. That is of fundamental importance and allows us to choose a dose that can be expected to give the best possible response. Similarly, the effect of age. So although we may not use these precise calculations in the clinic, we need to know which of these predicting factors are playing a part and use that information when we choose the dose of growth hormone to start a patient on. And when prediction models are used, the effect is that the poor responders are eliminated. As you see here, individual dose on the left, this is precision medicine, personalized medicine, compared with the standard dose used for all patients, which results in a large number of poor responders. And then we come to adherence. Now, adherence to growth hormone therapy is extremely important. Just look at the, I'm sure you know this figure from Cutfield, showing that poor adherence, you've got low, medium, and high adherence rates. Poor adherence results in poor growth. high adherence results in good growth. Now, there are a number of different factors involved in the whole adherence paradigm. You've got patient-related problems, disease-related problems, doctor-related problems, and treatment-related problems. So essentially, when we look at adherence, we need to get to grips with all of these different factors. But first of all, we need to be able to accurately measure the rate of adherence, whether it's 60%, 70%, 80%, etc. And in order to do that, the electronic auto-injector produced by Merck is of great value because you get automated dose delivery, tracking features, and particularly because you get a recording of every injection. Now, we know using the electronic injection device that adherence levels gradually diminish over time. And you can see these two examples of the percentage of adherence diminishing over time. So this is a real entity. Poor adherence occurs. Some people tend to dismiss it. It doesn't happen in my clinic. All my patients are very adherent, but that's incorrect. It does occur. And also, there is a direct relationship, as I've said, between the number of missed injections and the growth response, shown beautifully by these data. If the child doesn't miss any injections, they will grow much, much better than the child who is missing 4 or 5 injections a week. So here you have, with the use of this electronic injection device, a so-called digital ecosystem, which involves the patient, the injection device, the recording of data, the communication or the transmission of these data to the healthcare professionals, a patient support program, and I'll say a word about that in a moment, and then to the patients themselves, so they know that their rate of adherence is being monitored and is a basis for discussion. And this leads to essentially quality feedback from the healthcare professional to the patient and family, discussing what the problems are or could be leading to poor adherence. So you have this circulation of data, which is of extreme importance. And now Merck has 10 years experience of the use of this electronic device, and which has been used in over 40,000 patients in 39 countries, and which is constantly generating data which allows assessment. And again, it just reinforces high adherence, high growth, poor adherence, poor growth. So finally, we come to a patient support program, and Merck has also an electronic device which will help supporting the healthcare professional and the patient, and it allows a number of different factors or elements to be assessed. So, example, is the treatment too heavy an emotional burden? Is the child frightened by the treatment? Does the treatment cause anxiety? Is the patient able to self-administer, particularly in adolescence and during the transitional period? So these are all components of the adherence paradigm, which can be addressed as a result of having accurate adherence data. So artificial intelligence in pediatric endocrinology. I would simply ask you to look at this in a critical and objective way, because we are being flooded with propaganda that AI can do everything. Recently, we addressed this in an article which has just been published, and is available on PubMed. It's an open access article written by Paul Dimitri and myself. Artificial intelligence in pediatric endocrinology: conflict or cooperation. And we say what it can do, but we also say what it can't do. And I think this is important. So in conclusion, digital innovation can contribute in many ways: height screening, to some extent patient history, but not as good as the human, in my opinion, precision assays, height prediction models, monitoring of adherence, patient support programs, etc. What it cannot do is to establish and gauge the quality of a physician-patient relationship. And that's very important. Sensing psychological components such as anxiety, fear, and confidence. Assessing the quality of trust and commitment by the treating healthcare professional, and assessing the quality of the healthcare professional in terms of compliance and leadership. So thank you very much for listening. I hope you've been able to follow my talk virtually. I'd like to acknowledge these people, all of whom have helped me considerably, and I'd like to thank you for your attention. Thank you.
Professor Savage, for this fascinating and very realistic talk as usual. Time is not helping, but I think we can allow one question.
Okay.
Well,
I can't hear you.
well, we heard you well, Martin. It was a wonderful talk. Thank you.
Okay.
And I'm sort of fluttered by your compliment that you think in Leipzig we have a lower than average age at the start of therapy. We were trying hard, and I think we lowered it by 1 year in the end, which is...
Yeah, but I think that's good, Roland. And that's
Yes.
more than other people have done. So that's very good.
Yes. I think it's also, it is important.
Yeah, thank you.
Yeah, for the sake of time, our speaker,
I can't hear you.
Research interest in the beauty development and genetic aspect of growth hormone deficiency. He will give us a talk about his own experience. is
Hello? Can you hear
yes.
me? Can you see my slide?
Would you share your screen? Not yet. Would you please share your screen?
I've done it. It says that I'm in a common use of my screen with somebody else. Maybe that's why you can't see it. Okay, I can see it now. That's on your screen. Can you hear me? Hello? I don't get the feedback yet, but I can try to start my talk. Right. Can the others hear me? Yes, I hear that there's some sound. I can
You
start.
can start, bro.
Okay, thank you. I just wanted this feedback. Well, first of all, I would like to thank you for this kind invitation to your lovely meeting, and also for Sandoz to support me in participating. I would love to be there. I've never been in Jeddah, but from the pictures I see, it's a wonderful place. It's very cold here right now. We have a lot of snow, and yeah, we I would rather be at your place. I was asked to talk about our experience with a biosimilar called Omnitrope, which we have followed on the clinical basis in in a study that followed the patients for more than 10 years that have been treated with this biosimilar. I would like to give you some historical outview or about this type of treatment. And that's why I show you this picture, which sort of shortly sums up what happened in the childhood treatment of short stature due to growth hormone deficiency, basically, in the start. It goes back to the 1950s when Morris Rabin in the United States purified growth hormone from human pituitary organs and showed that it was effective in treating children with growth hormone deficiency. It obviously was very limited in the amount you could use at that time. And that's why in many countries around the world, there were banks instituted that collected these organs and produced growth hormone. And in the 1970s, then, it was Zhou Hao Li who first synthesized it, not recombinantly, but biochemically, which was an achievement per se. It took him more than 10 years to produce this complicated structure. And then, of course, the genetic recombinant technology was introduced, and it was produced recombinantly by the end of the 1970s. And in the 1981, it was first synthesized in E. coli, which is the form that we usually use when we treat. And at that time, in the early 1980s, this big tragedy occurred when the first patients that were treated with extracted growth hormone deficiency had shown signs of slow virus infection that was transferred with this substance, the so-called Jakob-Creutzfeldt disease. That made it easy, or that enhanced the treatment with recombinant growth hormone, which was the first recombinant hormone per se to be introduced in the market due to the fact that it was so limited in the amount. And Omnitrope is a substance, a biosimilar. It's the first, so to say, product or protein produced as a copy of one of the first growth hormones, which was the Pfizer's genotropin, to prove that it is pharmacologically equivalent, but biosimilar compared to a normal drug that is sold as a generic drug. Can you hear me? is more complicated in the way that you also have to prove that it is safe, not that only that it is comparable to the comparator, which is the genotropin, but it also has a similar safety. This is sort of a chronology of growth hormone in the treatment of children. The first indication, of course, with recombinant growth hormone was growth hormone deficiency. Second one, interestingly, being chronic renal failure. Turner syndrome in 1996, Prader-Willi around 2000. The small for gestational age, at least in part of the world, is an indication for growth hormone treatment. Idiopathic stature limited to some countries around the world as an indication. Shocks also limited to some regions, and Noonan syndrome recently introduced as an why was safety such an issue? Well, it may be also that I give you a short memory or a sum up of what has been done. The short-term safety has been tested actually in the first years since growth hormone was introduced on the market. But long-term safety still was an issue. And it is due to the initiative of our colleagues in France that such an roundup of investigations was undertaken to look at the patients that had been treated since 1980s with growth hormone and looked what happened to them after they had stopped treatment or after they have been put on an adult replacement dose. And this study was a common attempt of several European countries, Belgium, France, Germany, Italy, Netherlands, Sweden, Switzerland, and the United Kingdom. So altogether, we were able to collect data of about 25,000 patients that had been treated. You're probably aware of the SARS study. It has been published in several papers, referring efficacy, safety, and the influence of life quality. One of the things which I always think is important to mention that and this was basically done on clinical experience, but it still was done arbitrarily. We subdivided the groups that had been treated into different risk groups. The risk stratification was done that way, which is depicted here in the table. 1A being the lowest, isolated growth hormone deficiency, idiopathic short stature, psychosocial short stature, or short stature due to mild forms of a bone disorder. They were considered to have a lower risk overall on their medical health. 1B, and this is important because this makes up quite a proportion of the patients that we treat with growth hormone, is the patients that were born small for gestational age without a catch-up growth after therapy. We all know that they have an increased risk of disorders like metabolic disorders, a higher blood pressure, and probably have to be seen separately from the others within the low risk group. Then we have an intermediate group, 2, with multiple pituitary hormone deficiency, syndromal short stature, or short stature following severe chronic diseases. And we just talked about this patients with achondroplasia, which have been sometimes treated with growth hormone, but to my knowledge, with very limited access. So this is not comparable with what you heard about the treatments that are undertaken with fusoritide. And the highest group, obviously, being the group that had tumors that resulted in growth hormone deficiency. We all need, aware of these patients that have been growth hormone deficiency as a consequence of a brain tumor or a tumor treatment like irradiation or chemotherapy. That is what the profile of these patients was. This was the achieved age within the study, meaning the average age that the patient were observed when we performed the study. And you see the average age was about 30 years, 35 years. So they were still young adults. The time after the start of therapy was about 20 to 25 years. So this is the time that actually was observable after exposure, as we called it, to growth hormone. The overall number of the patients you see down here it's an impressive number, but if you divide those groups and then look into particular diseases that had been involved in the diagnosis and treatment of the growth disorders, it in some groups really fell down to only a few patients. And that sort of symbolizes or exemplifies the problem with these studies, that in special circumstances, you're still left with an open question, of course. You can't be that sure. Well, the things that at that time rose the attention of most of, or a big or majority of the pediatric endocrinologists that had used or are still using growth hormone was questions like this. That it was a study that didn't cover the whole SARS group. It was the French group that was the first to sort of collect the data and that published their data, and that saw a correlation of the treatment with the dose used during the treatment. This is the dose in microgram per kilograms per day. And you see that the standard mortality ratio, which means the mortality of a patient group compared to the normal population, is slightly increased and increases with the dosages used, more than 50 micrograms per kilogram per day, in the study. You also see that the numbers go down here, which may give a statistical problem. And this is something that we also have to mention, these French studies were the first with a limited number of patients involved. When we included the rest of the team, the other European countries that then joined the SARS project, the data didn't turn out to be significant in the end. This is something that has to be mentioned at this point, and which is important to notice. It's also, and that is probably nothing new to you, it's also dependent, of course, if on the reference population. If you have different reference populations, reference populations that have a high standard of living or a healthy living style, like they use healthy food, or are living in parts of the country, you get different outcomes, of course. And this is sort of shown here. This is the second French population where they showed that in the SGA group, especially, they could encounter an increased number of ischemic insults, cerebral insults that, as I said, did not turn out to be statistically significant if we had put it against the rest of the European population. But it's difficult to rule out or to extinguish such findings, even if you have a very high number of patients, like the 25,000 patients that we had in the SARS study in the end. This is just to show you that as we were asked to do security and efficacy surveillance of patients treated with the first biosimilar ever, which was Omnitrope, obviously a recombinant human growth hormone, we could go back to the phase 1 and phase 3 studies, obviously, with numerous participants, but this, of course, is not usable for safety data aggregation. These are numbers that would not give you any information. So we decided to do this marketing study called PACHO Children's Study that gathered more than 7,000 children with different indications for growth hormone treatment, like I showed you before, SGA, Turner syndrome, chronic renal failure, Prader-Willi syndrome. And so these are the numbers that we could enroll during these 10 years. 6,009 patients were enrolled. All patients included a safety set, which means we asked for the anamnestic, the historical diagnosis. We had 297 centers around the world. This was not limited to Europe. We had a mean age of the participants of 9 years. We had a slight predominance in the males, and this included the patients with Turner syndrome. And we had a proportion of patients that had been pre-treated with another growth hormone before the study. And this is one thing that goes back to Martin's lecture. The average duration of the growth hormone treatment was 35 months, which means 3 years. And why is that? That's because the age at diagnosis is so high. The mean daily dose of this growth hormone was 0.033 in these patients. This is, again, the gender distribution. There is a male predominance. Why is that? Well, you're probably aware of this. Usually, children are more worried about short boys than they are worried about short girls. Otherwise, it should be 50% on each of these heights. This is the distribution of the patients that have been treated. And you see the predominant indication was growth hormone deficiency, more than 75% held this indication, whereas SGA, small for gestational age, without catch-up growth, made up a quarter. And those are the other indications following. Well, and this is the issue again, high starting age. Is this due to our disability to make an early diagnosis? I would say yes, in partly. If you look at growth hormone deficiency, this is the everyday result. Patients that are seeing their doctors usually on frequent terms, but then are selected to be referred to the specialist around 10 years. Slightly lower 8.1 years. And I don't know how it is in your country, but in Europe, usually you are allowed to treat a patient born small for gestational age at the age about 4 years of age. So there's a gap of 4 years that patients had waited, maybe as they were seeing that the growth of the child was not going well, and it took some while. Interesting enough, the Prader-Willi patients are the ones to be earliest treated, but they are a small proportion of the overall group. The mean height, yes, they are small. And interesting, again, the Prader-Willi patients are not that small. So there are other reasons why physicians choose to put them on growth hormone. Oops. And the mean height velocity, well, the patients that were growing worst were those with chronic renal failure, which is stunning in a way. These are the patients that have renal insufficiency. They are growing well. Usually renal insufficiency occurs at one stage of your life later on, meaning not around birth. So these were imminent cases where the rest were growing at an SD of -2 when they started therapy, average of about 2.5. This is well be nothing new to you, but just as a member, it's just like in the other big treatment studies. Yes, we could prove that growth hormone improves height. The better, the more naive the patients were, meaning that they had not received other growth hormones before and were not pre-treated, showed the most stunning increase in their height SDS. This is an interesting phenomenon. These are the SGA-treated patients that were pre-treated compared to the SGA patients in red that were not pre-treated. Seemingly, they kept up growing, these pre-treated, but then sank. Why is that? Well, this is one explanation is that usually when you have been pre-treated and were put on growth hormone relatively late on the Omnitrope in this case and on the biosimilar, you will have surpassed the your zenith, the maximum point of growth, because you go into early puberty. And this is a phenomenon that you usually see in SGA-treated patients. If you start them too late, you will not be able to get the full benefit of the treatment because they will stop growing early. And here it seems they even lost, but that's not true because they have gained height before they have been put in the biosimilar. And this is the growth velocity or height velocity of the patients with growth hormone deficiency and SGA, and it's stunningly similar rates. They are growing better in the first year of life of treatment, and then this fades off to be still over the 0 percentile. They're still growing faster as their comparative growth, but that effect is waning, as you see. So yes, it is. We could also show in our data that more than the dosage of growth hormone that you use for treating your children, it is the age at onset of treatment which finally makes the difference in the gain of height. Once you stop treatment, this is the mean height SDS at start of therapy with documented adult heights. This is obviously smaller numbers, of course, because not all patients had attained adult height by the time we took the data. But you see that the gain in height is obviously, the best in the growth hormone deficient patients, just 1.2 SD, roughly 1 SD in the SGA patients, and roughly 1 SD in the Turner syndrome patient. Now to the side effects. The overall side effects were rare. We subdivided them into mild, moderate, and severe, and of the overall, and these are the occurrences of such side effects. The mild ones were the most frequent ones, where moderate ones were less frequent, and obviously the severe ones were with 4.2% the least frequently occurring side effects. Treatment-related, or that treatment was interrupted in 2.7% of the reported cases. So there is a percentage where, yes, it has a consequence on treatment. It's not permanently interrupted, and it was reduced in 1% of the cases. Well, the most frequent side effects of treatment that were attributed to be treatment-related, meaning to the treatment, not every side or adverse event is treatment-related, was headache. Usually, in 1.6% of the subjects at one point over a limited time, headache was reported. Injection site pain in 0.7%, injection site hematoma in 0.5%, arthralgia around 0.4%, and hypothyroidism 0.3%. So these are all well-known side effects with a frequency that have been reported before, also in the old recombinant growth hormone therapies. I just want to give you a short overview over those patients that had serious adverse side effects or adverse events. There were, and this means they had been admitted to the hospital, or they had to be seen by a doctor, and the consequence was inferred on the treatment. Serious adverse events were encountered in 6.5% of the subject, meaning they had to go to a doctor, maybe for, say, a pneumonia or an appendectomy. Only 0.6% one had a serious adverse event that was related to the treatment. And this is give you a short summary of those patients that are mentioned here. For example, there are 2 patients had been experienced intracranial hypertension. This serious adverse event resolved completely in both cases on its own without interrupting therapy. A 5-year-old girl with growth hormone experienced recurrence of craniopharyngioma with mild hydrocephalus. She was shunted due to, and she still continued growth hormone therapy in accordance with the decision of the treating physician. There was a progression of an underlying craniopharyngioma in a 19-year-old boy with growth hormone deficiency. They interrupted growth hormone temporarily and then started again. In an 8-year-old boy with growth hormone deficiency, he had, which had some sort of syndromal features with syndactyly and skeletal dysplasias. He experienced gaits disturbance. This SAE completely resolved on its own, but the treatment was stopped. because they were not sure whether this was. And then just to complete this list, a 6-year-old boy with SGA, a small for gestational age indication. He had adenoidal hypertrophy. He received surgery and didn't interrupt treatment. A patient had osteochondrosis. Growth hormone was discontinued. One patient developed type 1 diabetes in the whole cohort. His treatment was discontinued, and the 16-year-old boy had experienced acute cardiac injury to progression of his congenital pulmonary atresia. This SAE resolved after surgical correction, and patients did not interrupt growth hormone therapy. This is a busy slide. I just wanted to give you an overview of the studies that have been performed, both with substances, growth hormone that were introduced some more than 20 years ago or 30 years ago. This is the Nordinet study, the Genesis study that was was generated by the Lilly group, KICS, which was the Pfizer study, which was one of the biggest studies overall to follow children longitudinally after initiation of growth hormone therapy, and the NCGS study, which was the United States pendant for the KICS study. Also included quite a number of patients. This is the PATRI study, which is relatively small, as to say, but we had this emphasis on the security. When I explained to you why that was, this was sort of the outcomings after the SARS discussion, whether we had a very close focus on these adverse events that we documented, whether they were drug related or not drug related. And this is the occurrence of the incidence rate per 1,000 patient years of exposure to growth hormone. You can see we can list this according to whether it was an adverse event, a serious adverse event, and these are the drug-related adverse events. And this is what you have to they differentiate when you look at the studies. Not all of the studies at that time were able to register this different side effects. So all in all, in the PATRI study, we showed that this was a very similar profile of risk that you're incurring on your patient when you treat him. It is relatively safe. It shows that we need a lot of patients and the patient years to show and to have a grip on the risk in the individual risk of such treatment. But it also shows that risk assessment does not stop at the end of a growth hormone treatment. It goes longer than that, because things may occur that did not occur at the time of treatment. The risk assessment is very much dependent on the initial risk stratification and thereby on the correct diagnosis that justifies such growth hormone treatment, and the concomitant diseases during the therapy. And it's probably important to raise the awareness that the correct risk stratification of the so-called low risk groups is a conundrum, as it is so far under-identified disorders may populate this relatively large group of short-statured patients, meaning patients, for example, with idiopathic short stature, where we are at the moment learning a lot about the different pathophysiological backgrounds. The SARS study does not principally raise concerns in the long-term safety of the growth hormone treatment, but it raises further questions that need to be addressed. And the data collected in our PATRI children study is precious, as it can address these questions in the future if we're able to follow up our patients for some more years. And I thank you very much for the attention. And again, for the invitation to participate in your meeting. I'm open to questions.
Thanks a lot. Open the floor.
Hello. Yeah, now I hear you better. I couldn't understand you just right now.
Father, there is a recognition by giving you a certificate. Do we want you to be with us? So
Yes.
thank you very much for your contribution.
Thank you for your invitation and have a nice meeting.
Thank you. Have a good evening. Thank you.
وكما يسعدنا أن نكرم سعادة الدكتورة خيرية موسى رئيسة الجلسة مع البروف عبد الله الحربش. بارك الله فيك. شكرا جزيلا دكتورة. أتفضل دكتور عبد العزيز. هذه كده بس بيننا.
Grüß Sie, hallo. Sie wollten anrufen, dass Sie fertig sind, ne? Okay, ich habe Sie schon geschaltet. Da hat so gebrummt im Hintergrund. Kein Thema.
شكرا دكتورة بارك الله فيك.
Ja klar, ich komme rüber.
عندك ملاحظتين. الأولى دعوة من شركة فايزر لمشاركتهم في سناك بسيط وقطع الكيكة في القاعة المجاورة رقم 2. وأخيرا وليس بآخر، شكرا لحضوركم وصبركم إلى آخر لحظة من هذه الجلسة. نلتقي غدا بإذن الله السبت اليوم الثالث للمؤتمر وفي تمام الساعة 9 صباحا مع الجلسة رقم 8 إن شاء الله. شكرا والسلام عليكم ورحمة الله وبركاته.
Ladies and gentlemen, the Scientific and Organizing Committee